afternoon, Dr. Ajay. Hi, Ajay. Good afternoon.
Afternoon. This is Dr. Ganguly
From
from
AIIMS.
AIIMS.
I have with me Professor A. Sharif. Hello. Hello. No, right now we are on the audio, not on the
पैनल
video.
नहीं दिख रहा है? मैं यहाँ नहीं दिखा रहा हूँ, यहाँ पैनल पूरा.
So now you can see
Yeah,
the
yeah.
panel.
I'm Dr. Sharif. Hello. YouTube में वो दूसरा कैमरा अगर डाला है तो ये ब्लॉक करेगा वो कैमरा उसको. नहीं, वो पीछे वाला कैमरा से YouTube में भेज दो.
दीपक उनको बोलो अभी थोड़ा सा वो ऑफ करे वीडियो को ऑफ करे सुजन अभी वीडियो ऑफ करो जरा सुजन वहाँ से ऑफ किया तू उधर बैठ थोड़ा सा अरे ठीक है तू इधर उमेश तू वहाँ बैठ के जरा सुजन से वहाँ देख तो कितने पार्टिसिपेंट्स होते जा रहे हैं जरा देख श्वेता दोनों में से कोई एक है ना हम लोग भी वहाँ से फोटो ले लेना इसके ऊपर ज़्यादा विश्वास नहीं है ठीक है उसको भी वहाँ वो कोने में क्यों बैठ रही है उसको भी इधर बैठा दीपक
Very warm welcome to all the participants. I am Deepak Shukla, Librarian Grade 2, BV Dikshit Library, AIIMS, New Delhi. On behalf of AIIMS, New Delhi, it's my privilege and honor to welcome you all to today's webinar in collaboration with the World Bank Group on Digital Health Knowledge Connect 2022 Paradigm Shift in Research Information Management System. I am very thankful to AIIMS competent authorities and especially Dr. Shantanu Ganguly, Chief Librarian, for giving me this opportunity to welcome you all. On this auspicious day, amongst us, we have Professor A. Sharif, Professor and Head, Department of Anatomy, AIIMS New Delhi, Mr. Ajay Tandon, Lead Economist, HNP, the World Bank Group. Thank you, sir, for your kind support and guidance and also gracing the occasion. We also have galaxy of eminent resource persons such as Patrick, Senior Economist, World Bank, Peter Cracker, Founder and Chairman of Open Knowledge Maps, Swan Nielsen, Economist, the World Bank, Dr. Shantanu Ganguly, Chief Librarian, AIIMS, New Delhi, Seena Chabra, Senior Health Specialist, the World Bank. I hearty welcome to all the dignitaries. It's my humble request to all the participants, please follow the do's and don'ts during the session. Do's, make sure your microphone and camera is working properly. Participants can post their queries in the chat box. Don'ts, avoid noisy distractions during the presentation. Please don't share your screen during the session. You can share your query in the chat box only. And now I would like to invite Ms. Amita Rawat, World Bank, to setting the theme. Over to Amita Rawat, ma'am.
Bhutan, and Laos. Ajay received his PhD degree in economics from Virginia with a dissertation that focused on the intersection of macroeconomics and population dynamics. He has worked with the Evidence and Information for Policy Department at the World Health Organization. Well, this is an exciting day, and where we all have the privilege to hear many more things. But I would first like to invite Dr. Sharif and Ajay Tandon to welcome the participants before we do a deep dive into other sessions. So, Dr. Sharif.
Thank you, Dr. Ramita, for the nice words of introduction. And at the outset, I thank the organizers of this particular webinar on the Digital Health Knowledge Connect 2022, a paradigm shift in research information management system. I also thank all the functionaries and dignitaries from the World Bank for making this event happen. So, to set the ball rolling, I thought that I should share my experience of uh, my association with the information technology and how I have been managing my own research and my own information systems. And I also want to share my personal journey from a no-tech world to a high-tech world. Okay, so my introduction to the field of IT predates the actually coming in of the personal computers. So I started my journey in the early 80s when personal computers were not so commonplace. So, and my research started off when I joined my postgraduate degree at JIPMER Pondicherry, that was in 1986. And how did we manage our research at that time? I think that will give some kind of a perspective to where we are today and what our future is going to be. So, first of all, to start any research, we needed to identify some lacuna, that is, some kind of a gap in research. So, how do we do that? We have to do the search of the existing literature and find out the areas where enough knowledge is not available or there are some gray areas. Those we used to call them as the lacunae. So how did we go about doing that? So we used to get massive publications which were known as Index Medicus. I am not sure, most of the younger generation people may not have even seen those. So once in a month, that Index Medicus used to come to our libraries, and that contained the titles of all the research articles that have been indexed in the so-called Medline. Medline was a database which was actually the online format of what is known as Medlars. So Medlars is a database which started off from 1966, I think. So the online version of that was Medline, and even now the major source of citations in PubMed comes from the Medline database, and the PubMed is updated with new Medline entries on a daily basis. So anyway, now coming back to my old story, Index Medicus used to contain the titles of the articles that have been published in the so-called indexed journals. A few thousands were there, around 2 or 3,000 journals used to be there, included in that. So we used to note down the titles of relevance to us. We used to take the list and then go and hunt for those journals. Sometimes we used to find those journals in the library, which were really dusty and inaccessible corners of the library. So sometime, if we are lucky enough to spot a journal in the bulk of those things, and we used to get the article, and we used to get that article photocopied. And even before that, when photocopy was expensive and there was no availability of photocopy, we used to sit and write down the relevant, abstract or the notes or whatever kind of things. And many times it so happens that that particular issue of the journal was not seen. It was not in the location where it was supposed to be. And if we are lucky enough to locate the journal, the particular article that we needed was torn off. This was our experience of the literature search and starting off of the research. So it's like the person who needed that article reached before me, and he just took the easiest way of taking it was tear off that article from there. And one person had that and nobody else had access to that. Now you can imagine the situation. All millions of people can have a copy of the article at the same time. I think that was one paradigm shift. And after that, we used to do our research, whatever we were doing on the animals, in the labs, patients, whatever. And then we used to collect our references in the so-called, earlier we used to have cards. We used to write every reference which is relevant to us on cards and keep those cards, and that was our bibliography. But later on, in the mid 90s or something, we could get access to the so-called reference management systems. So we could actually input the citations in that particular this thing, and after that we were able to search within our own collection of a small database of the references which are relevant to us. Those were the reference management systems, and I think RefMan was one of the common things, and I used that also. And then after some time, so in early 90s, we could get access to the systems which had CDs with copies of the Medlar's database. Medlar's database CDs were supplied on a monthly basis to big institutions or the head offices of the information systems in the countries. Like NIC was one such place. NIC, National Informatics Center, used to get CDs, and we used to go to NIC, and there were 4 or 6 systems kept there which had access to those CDs. So we used to search the databases which were on the CDs using the so-called mesh. What exactly is this mesh? It is the medical subject headings. And the speciality of the Medline database was that it was indexed using those mesh headings. That was the best part. So we had to know the right mesh, the mesh medical subject headings to get the articles of relevance to our own research. I hope you are appreciating my journey through the reference retrieval systems, literature search. So now that was a great advancement, and we were so proud that we could just go there and get the whole thing on a floppy, copied on a floppy, and come back. And most of the time, the abstracts used to be available. The full text article was is a kind of a something we could dream of. So if the journal was subscribed in our own institution, we could go and get photocopies of that. So that was the best that we could do. So, and from there we have come. So the internet has become common. So I think the World Wide Web started off in the 90s, and that was one paradigm shift. The coming in of the World Wide Web made this PubMed available. PubMed was the online database search system which mainly had all the Medline. I think more than 28, 30 million citations are there probably in the PubMed, which includes indexed as well as non-indexed journals. I think the Medline database contains more than about 28 million citations. But then again, that we had to go through every title, the abstract, and then try to find out the full text articles, and then we had to read manually. And we were never sure that we have covered all the topics of all the all the papers of relevance to us. So we could not be 100% sure that our literature search was thorough. So that is why we always used to, to the best of our knowledge, probably this piece of information doesn't exist and no research has been done. But we could never be sure of that. Unless somebody else pointed out that, okay, an article was published about 5 years back and now you are saying that no research was done on this. Sometimes the author himself used to tell that I have published about this 5 years back and you didn't see that. So, and that was the state. That is why we could never be sure. And then after that, now, once the internet and PubMed have become available, the problem was different. We were overwhelmed by the number of articles that seem to be relevant to our field of interest. And then that is a second kind of problem. Earlier it was information paucity, and here it is information deluge. So again, but again, we had to very cleverly tailor our searches and form the queries in such a way that the most relevant articles to our research show up on the screen. So whatever it is, again, so we have been carrying on like that until the so-called artificial intelligence and big data analytics and all those things kicked in very recently. So now the searches are actually prioritized as per the relevance to the topic. Even if your query is not structured so cleverly, there is so much of machine learning, artificial intelligence which is being used in the background in the search engines like Google or PubMed. They are actually helping us now. So right now we can say that this is a current paradigm shift. So we have seen one paradigm shift from Index Medicus published materials to online materials. That is some kind of digitalization, not just digitalization of the knowledge has been there, and now the knowledge is available to everybody who needs it. It's a kind of a democratization of the knowledge is brought in by the advent of the internet and all the associated technologies. And now currently we are in a complete digital transformation era. And what are the technologies that are actually driving this digital transformation of everything? So in the industrial revolution parlance, this particular revolution is named as Industry 4.0. So now, how relevant is Industry 4.0 to healthcare? Healthcare is one of the biggest industries, and it is totally knowledge-based system. It's a knowledge-based industry. So what are the technologies? There are basically 9 technologies which are driving this digital transformation of everything in the world right now, and those are this cloud computing, big data, augmented reality, and integration of the systems, and Internet of Things, and additive manufacturing, which is commonly known as the 3D printing. 3D printing is a very simple form of the additive manufacturing. In additive manufacturing, there is much more because appropriate materials can actually be created when the product is being made. So that is one of the biggest industrial revolutions which we are witnessing right now. And what relevance does it have to medical field? One is prosthetics can be custom made for the particular patients, or even devices, medical devices can be manufactured using these additive manufacturing technologies. And then there are robotics, whether it is in healthcare procedures or operations or surgeries, or even in manufacturing of the healthcare equipments. So there can be autonomous robots. And then there are simulations. Like for example, how do simulations help in the healthcare field? Simulations help in planning the surgeries. They may help in education. We can actually illustrate and visualize difficult to explain concepts at the stage of learning. And at the stage of operation theater, even before the real surgery is done, the surgical planning and all the steps, everything can be thoroughly planned and rehearsed. So that is how the simulations will help. So these are the 9 technologies which are driving the digital transformation in every field, including the healthcare field. So now we are at a juncture where we can go to the next level of the paradigm by application of the artificial intelligence, artificial neural networks, and machine learning for research, information management systems, and how to manage the knowledge and make it accessible to everybody who needs it in the field at the right place at the right time. For example, healthcare institution has got a lot of knowledge. For example, one physician treats the patient in a particular way which he has learned throughout his lifetime of learning, and then now he provides a certain quality of care. Is the same quality of care provided by another physician in the same institution? Which is difficult to say. Then how do we get that knowledge which is there in the organization to everybody in the organization, so that the services rendered by the organization are fully taking advantage of all the knowledge that has accumulated in that particular organization? I think these are the things that we have to address, and probably this afternoon all our eminent speakers are going to throw some light onto how we are going to proceed from here. That is democratization of the knowledge and management of the knowledge in the organizations, whether it is research knowledge or otherwise, and how to make it available to the whole organization so that the organization and the society as well as the community benefits equally from all the knowledge that has been accumulated over course of years through research and through experience. I think with that I would like to stop here. And are there any queries?
Dr. Sharif, I think that was a very great insight into your journey. to give his own insights into the paradigm shifts that he thinks that attack analysis.
Thank you. Thank you.
Thanks very much, Ankur, and thanks also to Professor Sharif for the very interesting opening remarks. And in fact, I was going to say something similar to what you already said. And definitely, I am not from the generation that has not seen this. I still remember vividly. I did my postdoc in the Center for Study of African Economies at the University of Oxford. And part of my postdoc was I was sent to Ethiopia, and I still remember going to look for some journal articles, and I think it was the UN library, and got very excited that I found the bound copy of the journal article, only to open it and then see that somebody had actually organized the entire article. And at that time, this was in the late 1990s, I think I was only one of 150 internet connections that were there in Ethiopia, and it used to take, I think, 3 or 4 hours of constant attempts at trying to connect, simply to be able to get access to email, let alone to the web. But also, having seen sort of the challenges of a paper-based system, but I've also been part of that transition. So while I was doing my PhD studies, the internet came in, and this was also in the early 1990s. And as Professor Sharif mentioned, that there was this sudden shift from getting everything slowly and slowly online. I think, especially the journals coming online was a major paradigm shift, and I think we have, as I won't repeat what he said, but I think what is the challenge now is that we're in a world where there's so much or too much information, and not just in the scientific realm, but also if you look in social media, and it's not always clear what are some credible sources of information and data versus those that are not credible, sometimes deliberately so. And I just wanted to also underscore that COVID-19 has also highlighted the importance of data, in particular for health data. Fortunately or unfortunately, a lot of people are now very familiar with what is a test positivity rate and what is an R ratio and things like that, things that normally only epidemiologists would have known. We've had to learn and to understand and to interpret what that data means. And as Professor Sharif mentioned, great innovations happening in terms of as billing becomes computerized, as diagnosis becomes digital, and also the challenge of really how do you manage all this data information, and how do you leverage it for bettering the state of everybody. So in fact, I wanted to also highlight that the World Bank's recent World Development Report was on the topic of data for better lives. And just sort of the three big points that sort of laid the foundation of that report was how important data can be to leading to better lives. The government can use data to improve programs, to improve policies, to improve the targeting of resources, for instance, so that scarce resources go to the poor and vulnerable population groups. Similarly, the private sector can use data to fuel business models that can stimulate economic activity and also trade and other services, but also individuals empowered by data can then can hold better decisions, can make better decisions, and also to hold governments accountable. And I think the challenge now increasingly is how you make sense of so much that's out there, and what are credible sources and information and data versus those that are not. But also, I just wanted to highlight that there does remain also this digital divide, both within countries but also across countries. So we're also seeing certain sections of society who are able to utilize access
some of these benefits of digitization much more than others. Similarly, some countries are far more digitized than others. I think India is lucky in that regard, in that digital penetration is quite good relative to other developing countries. But certainly we want to make sure that that digital divide doesn't get ossified and lead differences in equity in terms of access to the whole lot of services and welfare improvement. So I'll stop here and look forward to I want to welcome you all again, and in particular would like to thank you that three of my favorite colleagues from the World Bank are joining. So looking forward to their presentations. Patrick Zunu, as well as Glenn Nielsen and Sheena Chawla. So I'll hand it back to you, Amita.
Yeah, yeah. Thanks so much, Ajay. That was very useful, and I'm sure we all have you have got a good picture of the paradigm shifts that we all have experienced at our own age and time. So we see that there's a towering demand in the health, towering rise in the healthcare sector, and as Ajay said, that most of it can be contributed to the pandemic. So to provide the best and state-of-the-art services, the healthcare professionals too are dependent on the knowledge systems that help them in the decision-making process and also provide them with an environment of continuous learning. The quality of service and care provided is also dependent on tools, support, and knowledge that health organizations have at their disposal. An optimal healthcare knowledge system can create an efficient flow of information from the providers to the consumers, which results in increased efficiency and productivity. In this webinar, we will try and explore that why adopting a healthcare knowledge management solution is crucial for providing the best possible patient care and experience. This is an exciting day, and we have the privilege of hearing from so many distinguished speakers. We have heard Dr. Shalib Ajay Tandon, we have Patrick, Peter Cracker, we have Patrick, Sven, and Sheena, who are also going to speak on the various important topics. But before we dive deeper, let me show you, the World Bank group has an open knowledge repository, which I'm sure can be accessed externally and will be very useful to all the participants and the panelists. So the link to the open knowledge repository by the World Bank is being shared in the chat. But Prashant, can you just
Yeah, I've shared the link.
share?
Do you want me to share the screen?
Yes.
Yeah. Can you see my screen?
Yeah, it's loading. So this is the open knowledge repository. The link is being shared to you in the chat. And this basically, you will find a lot of material in this repository on various topics. You can search, this is a very user-friendly repository. You can search information by topic, by dates, by regions, by titles, and also if you were one of them who contributed to this repository, you can also check that how many times actually somebody went through your article or whatever you contributed. So this is a very good repository, and I encourage all the participants to use it. We also have another external source. The link again will be shared in the chat. Prashant, can we see the e-library? This is the e-library which is externally available to all the participants. Again, a very useful repository. You can basically search for information via region-wise, topic-wise collections. You have a lot of data and stats. Actually, enough material to kickstart your research. Also, the research librarians at the World Bank Group, create these topic research guides, on various topics. So I'm showing you a list here. So you can just, Prashant, can you click on one? You can click on the e-health. Yeah, this is the e-health research guide that was created by me. This has actually all information that is good enough to kickstart your research, like data and statistics, the research resources, journals, news and media updates, so on and so forth. So if you are one of them who wants to use information on the e-health sector, you can make use of this guide. And if you have any suggestions, if you see that there's something that is not added here and that's actually a Bible in the area, then we will be most delighted to add that resource into that guide. So with that, I would like to mention that I would like to, invite Patrick Kuzuno from the World Bank Group to speak on SDG 3.0 and open knowledge. Patrick is currently a senior economist at the World Bank in the Health, Nutrition and Population Global Practice with the Secretariat of the Global Financing Facility. He has over 10 years of experience in the development economics, microeconomics, and health economics with a focus on sub-Saharan Africa. And prior to joining the bank as a young professional, Patrick was a postdoctoral fellow at the International Food Policy Research Institute in Washington, D.C. Over to you, Patrick.
Just checking before if you can hear me well.
Yeah, we are able to hear you, Patrick.
Thanks a lot. And thanks for the invitation to discuss about measurement of health SDG and open knowledge. It's really an honor and a great opportunity to step back a bit from the daily work and have this longer-term perspective on how our work has changed tremendously over the past decades in terms of accessing references and also data, and see how this can translate into sharpening the policy advice work that we're engaging. So I will be focusing today about global measurement issues, especially related to universal health coverage. So that's one of the targets and goals under SDG 3.0, so under health. And I will focus even more on financial protection and financial hardship in the context of UHE measurements and present a bit the work that's conducted by organizations like the World Bank and WHO. Let me share my screen first. I will be presenting a couple of slides. Can you see my screen? Is it okay?
Yes, we can.
Okay, very good. So in terms of outline, I'll be covering 4 points. I'll give some context around the SDG goals and the measurement framework. I'll be talking also a bit about the type of data that we need to conduct this monitoring. Thirdly, I will give a quick snapshot of the key results that we saw in terms of global monitoring of UHE based on the latest report that was released in December 21, and I'll be concluding and giving a bit of a perspective on the process as it went since 2015. So starting with the context in the measurement framework. So that work really began in around 2016, so it's relatively recent. And 2015 was an important year because it corresponded to the year with, after the international community, we shifted from the Millennium Development Goals, which had been adopted in 2000, so they were coming to an end in 2015. And so we're shifting towards the adoption of the Sustainable Development Goals. So the main change there during this transition was the first an expansion of the number of goals. We went from 8 global goals to 17. But it was not just the number of goals that changed, also the scope, the type of goals that the international community adopted went from mostly social goals under the MDGs to goals focusing more on inclusive growth and environmental protection. In terms of targets also, while the MDGs were mostly focused on developing countries, now the Sustainable Development Goals were encompassing all income group countries. And finally, in terms of consultation, there was a much more consultative process involved during the formulation of the SDGs, involving the UN member states and also civil society organizations. So it was not just goals set by a panel of experts. In parallel, the concept of a universal health coverage. So universal health coverage means that in any country, all the population can access to the essential health services they need without financial hardship. So that concept was getting much more traction also in the global agenda. I'm showing here two snapshots, one from Dr. Margaret Chan, which was at the time Director General of WHO, who coined UHE as being the single most powerful concept that public health had to offer. And that coincided also with the arrival of the World Bank as the global director. Tim Evans was really engaged in pushing that agenda at the forefront in the global health discussions. So in 2015, UHE was not a new concept, but there was but the clear measurement framework was missing. So the concept was presented already back in 2008 in the World Health Reports. And the idea was to present UHE as a cube which had three dimensions. One being looking at the breadth of coverage, so who is insured. Second, looking at the depth of universal health coverage, so which benefits are covered. And third, looking at the heights of coverage, what proportion of the total cost of using healthcare was covered. But while the concept was relatively clear in terms of how it was formulated, the measurement framework attached to it wasn't so clear. And so there was some papers here. This is a snapshot of a paper published in the Lancet, questioning a bit the mapping between concept and measures in terms of the UHE. So that's why in 2015, a measurement framework was proposed. So that was a joint measurement framework developed by WHO and the World Bank, but at the end of an extensive country consultation process, which also involved civil society organization. To give a snapshot of what this measurement framework is about, I'll be focusing on two dimensions which are key to universal health coverage. One is service coverage, and the second is financial protection and financial hardship. So in terms of service coverage, the focus of this measurement framework is really on the outcome space. So we're not really looking at what happens in terms of input and output of the health system, but we want to focus on the population side of things in terms of how much intervention the population is getting access to, the type of risk factor that are being reduced thanks to this intervention, and also how financial protection is really offered to the population. For services, there's an index that's constructed from using geometric means on the tracer indicators within and between four main categories. The first category is reproductive, maternal, newborn, and child health. Then there's a compartment looking at infectious disease control. There's also one dimension on non-communicable diseases, and finally, a look at service capacity and access. So for all the countries, these are the tracer indicators that were retained in this framework because they were relevant in terms of a cross-country comparison. So countries differ in terms of their health system and also in terms of the burden of disease they're exposed to. And this is kind of a set of minimum tracer indicators that were deemed as relevant for as many countries around the world as possible. Focusing not on global but country-specific monitoring, and these indicators can of course be augmented by other indicators that are relevant for to monitor progress towards UHE at the country level. The second dimension is financial protection, and here there are really two important notions to have in mind in terms of financial protection: is formal care and financial hardship. So if we start with the population in need of health care at the top of this figure, some of them are able to access care, so that's the part of the figure going to the right. But another part of the population is sometimes facing barriers to access and cannot access care. And part of these barriers are accounted for by financial barriers. And when population cannot access the needed healthcare due to financial barriers, we label that as being forward care, and we try to measure the extent to which that happened. When we are talking about financial hardship, we are focusing on the right part of the figure where the population can access care, but they have to pay for it through out-of-pocket payments. And when these out-of-pocket payments become so large that they represent more than, say, 10% or 25% of the population's budget, then we categorize these payments as being catastrophic. And sometimes this payment is not even as large as representing more than 10 or 25% of household budget, but they're sufficiently large to push the population below the poverty line, or even further below the poverty line for individuals that are already poor, but they need to spend out-of-pocket payment to access healthcare. So that's the financial hardship part of financial protection that we are trying to measure across countries. To go back to the SDGs now, so in 2015, the UHC becomes an explicit target, so it's target 3.8 in the SDGs, and that's under goal 3. So there are 2 indicators, one service coverage and one on financial hardship. But while UHC is under SDG 3.0, it also relates to other SDG indicators, such as the SDG 1 on poverty reduction or SDG 10, so on BBC inequality. In terms of monitoring, so since the measurement framework was developed in 2014, every 2 years, so the WHO and the World Bank work together in a joint report looking at universal health coverage to produce a global monitoring report. So there have been one in 2015, 17, all the way to the most recent in 2021. And in the most recent years, there has been a companion global monitoring report focusing on financial hardship. I'll talk now a bit about the type of data that we need to construct these measures. Really the first and most important ingredient are population surveys. So I'm talking here about the type of data that are needed to construct indicators on financial hardship. So we need nationally representative population surveys, typically conducted at the household level, so with sampling rates. Most household surveys from developing countries are made through collaboration with country national statistical offices. So it's important here to have like an open data sharing platform in place to get access to this data. And we also have access to data from high-income countries that are obtained, for example, from the Luxembourg Income Study database, from the household budget survey collection. So we need surveys, but we also need key variables that are collected through these surveys. We need information on out-of-pocket payment for health expenditure, ideally at the individual level, but most of the time we are working at the household level. We also need household characteristics, about the size, the composition, the geographical location of the household. A very important variable that we need access to is what we call the welfare aggregate. So most of the time we're working with the total consumption expenditure at the household level as being the welfare aggregate. Other times in some countries it's income that's used as the measure of welfare. We also need definitions around the poverty line to measure what's the population share being below and above the poverty line, and the extent to which out-of-pocket payments for health are pushing the population into poverty. So these poverty lines can be absolute. So those that are very often used in the work that the bank is doing in terms of monitoring poverty are $1.90 per person per day in higher income groups. So we can look at the 3.2 or $5.5 per person per day. But we also look at relative poverty line, which increase as average consumption or income increase in the country. And finally, because we're talking about countries with different currency units, we need to find a way to convert these currency units into comparable units. And so for that, we're using purchasing power parity factors. I'll talk a bit now about the data process that leads to the construction of these of the global aggregates for financial hardship. So first, the WHO and the World Bank are working in terms of data acquisition and data preparation in parallel. So the WHO has access to some data set, and we at the bank have access to other types of data. Sometimes these overlap, and when these overlap, then we prepare the data points and we bring them together to expose this data to a quality check process. So we look at internal consistency, but we also look at external consistency of this data. Once we do this comparison, then selected data points are submitted to country consultation to the WHO. So the numbers that we derive for financial protection and financial hardship are sent back to the countries, which tell us whether these are valid numbers that we can work with. Once we get the clearance from the countries, then the final data set is used to construct the global aggregates for financial hardship. So how that works, in an ideal situation, we want to calculate what's the share of the global population that's spending more than 10% of their budget on health. You would like to have, for a given year, all the countries in the world having a population survey. So here I'm lining up all the points around the certain reference here. So if we have that, then it's very simple. It's a very simple exercise. We just add up the population exposed to financial hardship in every country, and we sum this population to construct the global aggregate. In reality, though, we don't have that picture that's been lined up. So countries do not conduct a survey every year, and they do not conduct a survey in the same year. So what you have is a picture where sometimes you have reference points for a given year, but other times you don't, and you have a point a bit before or a bit after. So in that case, what we need to do is to really line up these points to the same reference year using regression estimations, and so that we are able to do the aggregation. Again, now a quick snapshot of the results from the latest monitoring report. So this was released in December 2021, so it was the first report after we got exposed globally to the COVID pandemic. So the report is divided in two main parts. Because we're using household surveys, most of the data that we have is really pre-pandemic data. So we're looking at pre-COVID trends in terms of the global and the regional results. But there's also a second section, which is a bit less relying on the data, but more on possible impact scenarios, looking at the effect that COVID had on health service utilization, on household welfare, but also on government fiscal space. In a nutshell, what we see in terms of service coverage is an improvement across the board, so across all income groups and regions. But if we look at financial hardship, we see that there has been two different trends. One declining trend in terms of global impoverishment, but that declining trend was mostly due to the fact that poverty reduction has made tremendous progress all the way up until pre-pandemic reference years. But we also more really see an increasing trend in terms of catastrophic health expenditure. So that's the pink line here. So we are seeing the percentage of the world population spending more than 10% of their budget increasing steadily between 2000 and 2017. In 2017, that share of the population represents very close to 1 billion individuals per year. And while the trends are declining in terms of impoverishment, they remain quite large in terms of the size. So overall, there's about 1.4 billion people in the world facing financial hardship. Most of them are population spending more than 10% of their budget on health. But there's also, in addition to that, about half a billion population which are not spending more than 10% of their budget on health, but they are spending enough to be either pushed below the poverty line or pushed even further below the poverty line. So poverty poor people spending out-of-pocket payment on health and pushed further below the into poverty. A couple of conclusion points now. So while the pre-COVID trends were favorable in terms of service coverage, we saw a worsening in terms of financial hardship. And then when COVID came, that resulted in a severe macroeconomic shock across the board, which translated into fiscal deficit and an increased level of indebtedness, which will likely tighten the available fiscal space for health in the near future. So stepping back now on the UHC measurements in the context of the SDG monitoring, this is a work that started in 2015, and some of the key ingredients it took to come to where it is now is really a continued and shared commitment by international organizations. Also a sound and clear measurement framework, which was supported by a wide and open consultation process involving academics, civil society, and government. And finally, the open data side of it, and also the analytics that were posted, for example, on Open Knowledge Repository or other open data platform, was really key in getting there in so little time. Going forward, there will be a need to improve even more like the type of data collection instruments that we rely on. Is more frequent and more meaningful data collection instruments so that we are able to say something about the crisis like COVID during the crisis or even very shortly after the crisis, instead of relying on household survey data that are usually long to produce and also quite costly for the country's perspective. I'll stop here and we're back to you. Thank you very much.
Thanks, Patrick. I think that was a real deep dive. We have a couple of questions for you. We are a little above the hour, but if you can just answer perhaps one or two questions, and then the other questions can be replied via email. There's a question from Manu Kumar. How do you address the issue of data distortion created on account of biased interpretation of medical data by use of Industry 4.0 tool?
I'm not sure I get all the question. Could you please repeat?
Yeah, I will repeat the question. The question says, how do you address the issue of data distortion created on account of biased interpretation of medical data by use of Industry 4.0 tool?
So I'm not sure I'm going to directly answer the question, but so how do we, what type of data are we collecting? So these are mostly data that we collect at the household level. So there's someone going in families and really sitting down with the main household respondent or the individual and asking about what has been health expenditure in this household for different items, for consultation, for transportation, for that. So we're trying to adopt like a standardized definition of what we include in out-of-pocket payment expenditure, but the perspective is not the perspective of the health system. So it's not a level of data collection that's performed at the service delivery point, so in the health system. So really focusing here on what services the population is getting. So there might be some bias associated to that. For example, bias related to big old data. So if I'm asking you, what have you spent in the past month or in the past year, you might remember, or you might also not remember sometimes. So the evaluators are trained to really make sure that they collect as accurate information as possible, but it's not, it's never a perfect information. And I think that's an important point for this work to give some perspective on this work, is that we don't have a perfect data collection instrument, but it's reasonably good and reasonably comparable across country, that we can, reliably produce these numbers. And I think that here, really having focusing on getting the best data collection instruments sometimes might be a bit detrimental to having a good enough picture that's sufficiently important to shape or inform the type of policy advice that we need to do. So sometimes the best is the enemy of the good.
Thanks, Patrick. I hope Manu Kumar did answer your question. So now we don't have actually much time for more questions, but people can put their questions in the chat, and we will have the panelists answer them via email. Over to you, you're very welcome. Over to you, Dr. Shantanu Ganguly.
Yeah, thank you, Amita. First of all, at the outset, let me thank World Bank group for accepting our invitation, and we have such August gathering here. Uh, and starting from some of the points, I think when we were discussing and deliberating on some of these things, like for example, I got a very interesting a tagline for this, not only for this event, for the future event also, which Professor Sharif talked about, the democratization of knowledge. That was the word. I think I should have uh, a next webinar on this using this particular word. It's a very interesting. Whereas in Ajay, when he was talking about more on digital divide and the data to lives. In fact, Dr. Ajay, I mean, in one of the World Development Report, it was on digital divide. I have referred them in. I think it was in 2015 or so, where it was extensively. I have used it, and there was a huge amount of data was there for different and how the divide was looked into it. And some of the very interesting aspect was Patrick also looked into on NCDs and infectious like service coverage index, and I was very amazed to see the next report of global monitoring. I don't know why I have missed it. Generally, I don't miss these kinds of reports. The GMR report has arrived, and where it's talked about the universal health coverage and SDG 3.8 and all those things. So it's very interesting and setting the ball rolling. Now I have my a very good friend Peter Cracker is here, and Dr. Peter Cracker. In fact, hi Peter, good to see you there. And he is the founder and chairman of the Open Knowledge Maps, a charitable non-profit organization dedicated for dramatically increasing the visibility of scientific knowledge for science and society alike. And Peter is a member of the Go Fair executive board, the coordinator of the Go Fair and implementing network on discovery, and a member of the Financial Sustainability Task Force of the EOSC associations. So over to you, Peter. We are very anxious, all of us, both online and offline, to hear you out. Over to Peter.
Thank you. Thank you very much for the kind invitation, for the kind introduction. I'm delighted, I'm honored to present Open Nourishments to here to you today. I'm going to share my screen here so you can see my slides. Yes, and also like to mention that this presentation is co-created together with Nourishment Sport colleague Maxi Schramm. And I want to start off with the motivation for our work, and I think it was mentioned already today. There is an information overload. There is just too much knowledge published, and we've seen, especially in the coronavirus pandemic, where now up to 600,000 research outputs have been created, that it gets very difficult to get an overview of the scientific topic and to then keep it. And it's not just literature, it's data sets. So we've spoken about data already, and many other outputs like research software that make it really difficult to understand the full picture. And one thing I think has become clear is that list-based search engines such as Google Scholar are not enough anymore to keep up with the growing knowledge. I think they're very useful when you already know what you're looking for, when the information need is well defined. But it's no tool to get an overview of 200,000, 500,000, 600,000 papers. And this was the starting point for open knowledge maps. So already now over 5 years ago, we founded this charitable nonprofit organization in Vienna, in Austria. and we're dedicated to dramatically improving the visibility of scientific knowledge. And we want to do that for science, for academia, but also for stakeholders outside of academia, such as policymakers, public health officials, journalists. They often have a much more difficult journey into scientific knowledge than those that are already in academia. The approach that we've taken are knowledge maps, and they have a number of advantages over a list-based system. As you can see in this example, for heart diseases, we have the main areas at a glance. So here we have risk factors, types of diseases, and prevention. And we have already relevant resources attached to each of these areas. Also, the closeness of the bubble says something about their subject similarity. So in this example, types of diseases is closer subject-wise to prevention than it is to risk factors. From the theory to the practice, if you go to our website, openknowledgemap.org, you can create a knowledge map of your own. We have integrated two databases, PubMed, both has been mentioned already today. I'm going to show a PubMed example later. But for now, I'm showing a more general example using the Bielefeld Academic Search Engine, which indexes over 280 million scientific documents. And so you can search in any discipline. And I've taken the example of digital education here. And as you can see, we create the knowledge map then for you, and it looks very similar to the example that I've shown you earlier, in that these bubbles represent the sub-areas. So we have education systems, education policy, digital literacy. And once you've found an area that you're really interested in, let's say the one on digital competence up here, you can then zoom into it. You can see the resources that are related to this area, and you can inspect the different publications, including the metadata. And if it's an open access publication, you can also view the PDF within the same interface. So this is the basic functionality that we have. The advantages that this kind of system brings is that it gives you a bird's eye view of the field. So something that's very difficult to get with other means, you can identify relevant concepts. So this is often the most difficult thing when getting into a new field is to understand the terminology. You can sort the relevant from the irrelevant depending on your information need. So if you're only interested in digital competence and digital literacy, you can first stay within those two bubbles and then maybe branch out only later. And Open Knowledge Maps is an interface for all scientific knowledge, so both open science and closed science, but we will always make it very easy to find the open content and then to directly access it. And to further accentuate these points, I'm now going to show you a live demo of the PubMed integration. And when I was researching this talk, when I was putting it together, I saw a news article about cases of hepatitis in children that are not caused by the hepatitis virus, but are rather linked to the adenovirus. And so I thought it would be interesting to map that relationship. And you can then see that the resulting knowledge map now is based on PubMed. And again, the bubbles here represent the sub-areas. And down here, for example, we have clusters on this relationship in FAR, but also up here about the epidemiology of the adenovirus. And I'm going to zoom into this bubble. And one of the things that we've done in the PubMed integration is that we've included the citations. So the citations are used to scale the papers, scale the bubbles. The bigger the bubble, the bigger the paper, the more citations it has received. And it might be a good indication of which papers could be overview works, reviews that you might want to start with. So this could be a suitable candidate. And then you can branch out into other areas of the map. If you're interested more in this relationship in power, also marine animals, but there are also others like the one up here where you can look at this relationship in humans. Another thing that is possible is to refine your search and actually look not at the most relevant papers, but the most recent papers. And that then gives you also a different look at the same topic, in the sense that it shows you the things that are being researched right now. So how does it work? For an open knowledge mass visualization, we take the 100 most relevant documents from either base or PubMed, and we then use text similarity to group the papers together in buffers and in the layout. In a bit more detail, it looks like this. So we get the results from the base or the PubMed API, then we do a lot of pre-processing, and then we create a big co-word occurrence matrix of the words in the metadata, and that is then the input for clustering and cluster labeling algorithms, which gives you the buffers, and then two layout algorithms, which complete the map representation. So machine learning is one big part of what we do, but and the second big part are actually the cognitive aspects, because we're talking about knowledge visualization, and their cognition, of course, is very important. And we do follow the outcomes from cognitive science here, in that we try to reduce the cognitive load and restrict the number of elements in each view. We also take change blindness into account, so that means that our brain at the end of an animation does not remember anymore how the scene looked like at the beginning of the animation. That, of course, adds a lot of trouble for the interpretation. So we use animations only when necessary. We always provide ample context for orientation. And we also try to use well-known metaphors, real-world representations, so users instantly recognize the things in the map. And that's why, for example, in our visualization, a paper looks like the icon of a paper and not another circle. With this approach, we've become the largest visual search engine for research. So we have more than 1.7 million visits on our website so far, more than 850,000 webs were created, and we were happy to welcome more than 4,500 participants in our online and offline workshops. All of our services are free and open, so we're an open infrastructure in the strictest sense, and we're built on the principles of open science. And so everything is available. That includes the search and discovery services that I've just shown you. We also have new ways of integrating open knowledge maps into institutions, into our platforms that I will talk about a little later on. But also our training materials, our software, are all openly licensed, and our community supported engagement programs are free of charge. All of this is funded by research projects and increasingly also by supporting members. So we're very happy to have these institutions. So here you can see the 20 organizations that are already with us. And they are not only supporting us financially, they're also providing a lot of input on the direction that we're taking in a technical sense. We also found many advisors from the open science and open knowledge world, which give us good guidance on how to develop the tool and the organization. And we have a very active user community. Here you can see our enthusiasts. So these are power users and ambassadors from all around the world who are carrying workshops, carrying out workshops in their own communities, and then bring the feedback back to us. I've already talked about the training materials. They are available on our website, and they enable a lot of trainings. You can see them in various places. Here we have online trainings from our supporting members, but also there are a lot of online trainings from our active user communities. Another part of the world here are two examples from Indonesia. Yeah, and I've already talked about the institutional integration, and this is the last point that I want to make in my presentation, in that we have developed the custom services, and they are a way to embed open knowledge maps components in your own discovery system. They are co-created together with our community, and they are available as cloud components, so they're easy to install and integrate. How does that look like? So I've taken the example of a European Union project that we're involved in called Tripper, and the outcome is the Go Tripper platform, which is part of the European Open Science Cloud, and it provides discovery in the social sciences and the humanities. The way it works, you can type in your topic. Again, I've taken the digital education as an example. And you then get a list-based search, as you would probably expect. But then you also have the ability to create a knowledge map on the same topic and get a very different view of the contents of the platform, and maybe a better way of starting out on the platform, on the topic, and the things that you're interested in. In terms of the technical setup, we have the institutions and platforms down here, and they send their data to base, our common aggregator, and then we have access to this data, and we can provide these components back to you. The benefits are that you can increase the discoverability of the contents in your knowledge platform. You can attract new audiences, so knowledge map has been shown to be very efficient across age groups, across geographic regions. We really have a worldwide user base, and children as young as 10 have actually been able to interact with the visualization. We also enhance the metadata with our machine learning algorithms, but we always, of course, use a human knowledge as the gold standard. So we only try to enrich the knowledge, not override what, for example, librarians have already enriched. And with open knowledge maps, we hope to contribute to the sustainable development goal, of course, especially to inclusive infrastructure, but also to quality education and to increasing health and the well-being of the world population. Yeah, in terms of funding, and this is the final point that I want to make, is that we have adopted a community-based funding, because Open Knowledge Maps is a community-owned and community-based infrastructure. So we're asking organizations to become members of the association and then to provide an annual membership fee. And in return, we invite our members to co-create the platform together with us. So members become part of the board of supporters, and this board of supporters is directly involved in deciding the technical roadmap for the following year. So we're trying to think about infrastructure in a different way, in an open, in an inclusive way, and that's why we also have opted to go for very low membership fees. You can see the number on the left here is always the number for low and middle income countries. And so we would love to have a global representation in the infrastructure and a community, a global community developing this tool and this service together with us. And with this, I want to thank you for your attention, and I'm looking forward to your comments and questions. Thank you very much for the invitation.
Thank you very much. Thank you very much, Peter, for such an excellent presentation. And I remember last time when we interacted. Well, at that time, I think your Open Knowledge Maps platform was there, but not the Go Triple. But this time, I could see that you have already innovated in the social science sector and in the humanities sectors, and you have brought out the new model into it. Certainly, it's a very interesting thing and all. I just want to find out that if there are any questions, please pose it on the chat so that we can take it up with one or two questions with the Peter. Otherwise, I'll go for I'll put it on Dr. Prashant Ghanta once more. So, any questions on the chat? Can you have a look at it? Any question for Peter? Anybody wants to have any question for Peter? No, as such, there is no question as such. So over to Dr. Prashant Ganta. Prashant, please.
Thank you, Dr. Shantu. It was very insightful sessions from Patrick and Peter. Thank you. So now we move on. My name is Prashant Ganta. I'm a Chennai-based research librarian from the World Bank Group. To move on in the event, our next speaker for today is Sven Nielsen. Let me introduce Sven. Dr. Sven Nielsen is an economist in the World Bank's Health, Nutrition and Population Global Practice, where he focuses on measurement and tracking of Sustainable Development Goal 3.8, universal health coverage. And he is involved in evaluating and implementing health financing reforms in low and middle income countries. Sven also has extensively studied the impacts of health coverage extensions and health shocks on out of pocket medical payment, health service coverage, and household consumption among the poor in Thailand and Peru. So, without any delay, let's hear from Sven, who would speak on research visualization. Please, Sven, over to you. Thank you.
Thank you so much. It's a pleasure to be with you today. Many thanks for giving us this opportunity to present. I'm gonna share my screen. This is presentation mode, and hope is coming out bright and visible to you. If you go to the first slide, actually. Yes. Well, yeah, great. So, yeah, as you've heard, I'm working a lot on global measurement of universal health coverage and health financing. So, what I'm going to talk about today is not exactly the core part of my expertise, but I think from this exercise of global monitoring and trying to communicate the findings on where we are on UHC, we have looked into using some interesting visualization tools that I'm going to present. But my background is not in graphic design, as you might wish for such a presentation, but more in the measurements. But yeah, let's see if I have something interesting to add. Before we delve into how we visualize universal health coverage, let us remind ourselves really quick for the folks that are not spending 100% of their time on health, what universal health coverage is or is defined. So, kind of the definition by WHO, everyone receives the health services they need without suffering financial hardship. So what we see here that we have at least three dimensions of that concept, which are visualized by WHO in the famous slash infamous WHO coverage, health coverage cube. Many of you might have seen it. A lot of us cannot unsee it anymore because we've seen it so often. But this cube basically gives you the different dimensions of universal health coverage that all need to be basically covered in order to achieve this comprehensive universal coverage for the population. So that inner blue cube needs to basically extend to the full range of these different axes, which are the green axis, who is covered, is everyone covered, if not everyone is covered, who is covered, is it the rich that are only covered, is the poor, so this covers the level of population coverage, but also equity aspects. Then we have the pink axis here, services, which services are covered, and that entails not only curative care, it also entails prevention, palliative care, rehabilitation, etc., etc. So you will see that basically everybody has access to what they need, the basic essentials, are comprehensive. And it not only means, and we're going to go into this with visualization, that people have access to services, it also means that they have access to quality services. So the quality aspect is something that we need to capture if we're serious about measuring UHC and visualizing UHC. And then the third dimension in the cube is the direct costs. So what proportion of the cost is covered? And that refers to financial protection in the hospital, the cost covered for the patient. So that Patrick has talked about that at length. We don't want to reduce the share of the population that experiences catastrophic, impoverishing,
health spending, and that for both for financial reasons. So you see, this is just to exemplify. It's a very comprehensive concept you will see, and if we want to measure this for global monitoring work, and if we want to visualize that, we must take all these dimensions into account. You can't do that in one graph everything, but ideally you show things side by side, or maybe integrate one, two, three dimensions into one graph to really highlight that all these kind of bases need to be covered. So I'm going to give you just a brief flavor of how we do this today. There's two examples. One example are the bivariate choropleth maps that I'm going to use to visualize jointly the distribution of service coverage and financial protection. And the second one are so-called contour charts. Contour charts can be used for many purposes. What we're going to use them for today is to visualize gaps between coverage and what we call effective coverage, which is the share of the population that has access to quality healthcare services as opposed to just to health services of unknown quality. So let's start with the bivariate choropleth maps. So all of us know the univariate choropleth maps that are basically maps you can use to show for normalized variables, so rates or indices, where in the world they are concentrated. And I'm showing you there on the right is the WHO Service Coverage Index 2019 that underlies the global measurement, the global monitoring report of service coverage access in the world. It's made up of different dimensions like maternal and child health, NCDs, prevention, curative care, system readiness, etc. The way I've classified the categories here, as you see in the legend, for this index, it ranges from 1 to 100, 0 to 100, where low values indicate poor service coverage and high values indicate better service coverage, is into four equal interval categories. And you see that usual suspects, like the high income countries, they tend to have good coverage, so they're dark green. You look at Europe, North America, etc. But then there are other countries that are more in the middle income bracket, upper middle income, like Thailand, like China, that actually look that achieve quite high levels of service coverage. And you look at India and other parts of South Asia, they don't look so bad either. So in terms of service coverage, while it's not perfect, India is not doing so bad, right? You see it in that green. Africa, by comparison, still has a long ways to go. So generally on these profile maps, like what you see here is like using these equal interval categories. There are other ways to group the data. You can quintiles or for box plot classification, fractions, standard deviations. You can customize, etc., etc. And the way you classify the data, you classify the categories, of course, has implications for how you interpret the data. But yeah, it goes a bit beyond the time we have today to go into this deeper. They are implemented in Excel, in R, in Tableau, etc. And there are links underlying these dimensions on the slides that you can be able to access when you have access to the slides. So, service coverage, you see that picture that I draw. So many nations doing well in terms of service coverage, others on the way. And we could assume that this is all we need to do to measure progress towards UHC, right? If that is all the information we need for our Q, but we know our Q entails more things than the service coverage. And if we add a univariate choropleth maps on financial protection, and I'm using here the share of the population spending more than 10% of their household budget for out-of-pocket medical payments, you see that the picture is quite different, right? So you have some countries, North America again, then parts of Europe, my own Germany there, that do well in terms of financial protection, as well as on service coverage. So they're green in both maps. But then you look to Asia and South Asia, and there you see a big discrepancy. So China, for instance, right, is green in terms of service coverage, good achievement, but it's not doing well in terms of financial protection. It's red, right? So that means 20 to 36%, somewhere there in this range of people in China spend more than 10% of their household budget on health. So similar, unfortunately, in India, where we also have a very high share of the population suffering financial hardship in health. So if we only look at one of those maps without looking at the other, we're not getting the full picture in terms of universal health coverage. So we gotta fix this. And one way to fix this is the bivariate choropleth maps that basically allows you to combine two different variables in one map and see their overlap or the agreement, right? And I've done that here for the service coverage index and the financial protection indicator of catastrophic spending index, 10%. And by kind of overlaying these two separate univariate choropleth maps, we can basically detect whether countries are kind of like on a kind of straight path towards UHC, or whether progress towards UHC is kind of sequential, whether you reach service coverage first and then you work on financial protection, or whether these things go in lockstep. And in order to interpret this map, let's have a zoom in on the legend, right? So if you start from the bottom left and you go up the diagonal to the upper right corner, so from red to light green, these are the countries that where financial protection and service coverage move in lockstep, right? The red countries, some of those in Africa, have low service coverage. They have a high share of the population experience financial hardship. The brown countries, kind of in the mid-range for both financial protection and service coverage. You see a lot of these countries in the former Soviet Union who face that situation. A lot of Eastern Europe, so the Soviet bloc with their particular healthcare system seems to be in that category a lot, but also parts of South America. And then you have the green countries in the upper right corner, the universal health coverage achievers, that have high service coverage and good financial protection and low share of catastrophic spending. And with this index and that measurement of financial protection, it's only two countries, as far as I can see, that achieve that. Again, Germany, and I've not manipulated the data because I'm German. And then there's also Thailand, which I worked on a lot for UC. So there's definitely a correlation there. I'm not going to take too much credit for it, though. And then if you look at basically the far left of the legend and the vertical line, right? So everything that is kind of starts from brighter red and then goes to pinkish and then to kind of like a beige. These are countries with very low service coverage and improving levels of financial protection. So a lot of countries in Africa actually, they have low service coverage and they have decent financial protection actually. But this is to indicate not that these countries actually protect their citizens very well from high level spending. It is to indicate basically that people don't spend a lot on out of pocket on healthcare because they just cannot afford to go at all, right? So there's a lot of foregoing of care for financial reasons, for geographic reasons, etc., etc. So if we are on that kind of vertical axis on the far left of the legend with the colors, it does not indicate good financial protection. It indicates a lot of foregoing of care. By contrast, if we are moving on the horizontal axis at the bottom of the legend, these are countries that are improving in terms of service coverage from left to right, but they all have very bad financial protection. So that means folks are using healthcare, but they're also spending a lot of money on healthcare. And that is where you have China, that is where you have India, that is where you have pretty much all of South Asia. That's the situation there. You're doing better and better in terms of service coverage, but financial protection is still very much dismal and a big challenge. So you can derive a lot of policy implications from these. Just a couple of words on the method before we move on to the contours. So from a visual processing perspective, you don't want to go beyond three categories
for each variable, right? And you have to make judgment calls what that is, so you define the cutoffs. Some maps use 4 dimensions, but they are, I guess, like already challenging depending on how fit you are, how old you are, how many hours you work before you look at the maps. And luckily, the code for these things is available in more and more packages. Of course, you can cobble that together in Excel, but there's not a routine for that yet, unlike for the universe. But there's code for R, tableaus, data, and something like that. And those relates these dimensions in this station. So let's talk a bit about the contour charts that allow us to kind of see the gaps between coverage and effective coverage. So first of all, about the motivation for these charts. The motivation comes from the observation that while we have achieved a lot of progress in terms of service coverage in the last 2 decades, around particular the maternal and child health services that are stipulated in the MDGs. Some studies have found that actually the impact on health outcomes, mortality, maternal, infant, is not so impressive. So they haven't kept, they have not followed, tracked the improvements in service coverage. And in some cases, even we find negative correlations between higher access to services and health outcomes, which of course we don't want that people go to the doctor and they actually come out less healthy than they were before. So for that reason, people are increasingly interested in the concept of effective coverage. So they don't just want to know the share of people that access care, they want to know the share of people that access care and actually receive quality care. And I'm citing, you could call it a seminal paper in this literature, and one of the co-authors is present here. He was lost in the et-als, but I just wanted to point that out. It's Ajay not being visible off the list in this presentation, but his contribution to this paper, like in all the papers he's involved in, probably absolutely crucial. So before we go into the contours, a bit of conceptual reflection first. So the effective coverage is often displayed in what we call a care cascade. So starting on the very left, we define prevalence as the number of people with an illness or a condition like pregnancy divided by the population. So, what share of the population has healthcare needs. And then the next step, we define coverage as the people who actually see a healthcare provider as a share of the people in healthcare needs, right? So B divided by A here. So the subset of people prevalence to those who see a doctor. Then the third and rightmost part of this care cascade is the people who are correctly diagnosed and treated. So those among the people who seek care who get correct treatment. So subgroup of folks with coverage, they get correct treatment, and we define that as quality, C divided by E in that terminology. And we will see that with these two concepts or two rates, the coverage rate and the quality rate, basically, we can compute the effective coverage rate. So you take coverage treated divided by prevalence and you multiply that with quality, so correctly treated among the treated. And you can see that in that equation, if you move to the middle there, that the two B's cancel out, right? In the numerator and denominator, and you end up with effective coverage defined as the number of people correctly treated divided by the number of people in need of care. The share of the population that that receives correct treatment out of those with need of care is effective coverage. It is changed by multiplying coverage and quality. And this formula leads us to the contour charts. Before we fill this with data, just very briefly on how these look like. So
On the y-axis, here we put the quality, the share of people who seek treatment, who get correct treatment, and on the x-axis we have coverage, the share of people in need who actually see a healthcare provider. And the key part of these charts is the so-called isopoints. The isopoints, these curves, these blue curves, show you different combinations of coverage and quality that yield the same level of effective coverage. Let me exemplify that with a couple of fictive countries. So country A has lies basically on the isopoint of 10% effective coverage. That is the result of the country having a coverage rate of 20%. So very few people go to the doctor, and a quality rate of 50%. So those few people who go to the doctor actually get, more or less decent care. Every second person who goes to the doctor gets decent care. Multiplying 20% by 50% gives 10%. So the effective coverage rate 10%. Now we look at the second country on that same isopoint, so same level of effective coverage, but achieving a 10% effective coverage with a different combination of quality and coverage. So 25% of the people who go to the doctor, which are 40%, receive quality care. So more people access care, but quality is really bad. So it's a different combination of quality and coverage, but you end up at the same level of effective coverage as country A. Now let's as a final one, look at an overachiever here, so in country C, where 75% of the people see a doctor for their condition, and 80% of those people who see a doctor for their condition actually get quality care, which results in an effective coverage rate of 60%. So what you want to strive for, as you see in this map, is to be in the upper right corner of that contour chart. That is where you have both high quality, high coverage rates and high quality rates. You want to move up basically that isopoint mountain from the bottom left of this graph to the upper right corner. Let's do this with data as the last step before I close. So these are data points for antenatal care visits from mixed countries, multiple cluster survey data. So the multiple indicator cluster survey is a household survey on maternal and child health, service coverage, and health outcomes. And here we define coverage as the share of women that are pregnant that are in need of care that have any antenatal care visits. Basically just go see somebody for antenatal care. We define quality as those women that are pregnant and have at least one antenatal care visit, who also have 4+ antenatal care visits, see a skilled provider, have their blood pressure taken, and have blood and urine samples taken. So that's what we define as correct treatment. This is not the protocol, right? WHO is not the full protocol, but it's as far as we get with the household survey data at hand. And fortunately, these household surveys have more and more detailed data on quality, so we can get closer to protocol, medical protocol, clinical protocol by measuring quality. Anyways, so you see here that a lot of the countries that we have mixed data for, they are in the upper right corner. So this is great news. Countries with both coverage and high coverage and high quality. But then you see that while there are a lot of countries that have high coverage also, there are also many that have poor quality. So if you look at basically the middle of the y-axis here for quality, and you go to the very right where people have a lot of coverage, you see a lot of countries like Vietnam 2013 here, Zimbabwe 2014, and I don't have a pointer ready for the presentation, but all these countries that have high coverage, but mediocre quality, there we have a lot of work to do still, and that work mainly lies in improving the quality. Now, if you turn to countries that are kind of at the middle, around 50% of coverage and low quality levels, like Afghanistan, South Sudan, 2010 is there, that are around this effective coverage isopoint of 10%. There, of course, we have a lot of work to do, both in extending coverage, getting people to the facilities, and in improving quality. So this chart shows us
basically where we need to push the frontier. Do we have to push it in terms of coverage? Do we have to push it in terms of quality? Do we have to push it in both dimensions? So that Concord tries to do pharmacy policy wise in that sense as well. And there was oh yeah, last thing I want to mention. So here I'm comparing countries. So we have countries shown in terms of quality and coverage. But you can also, of course, do that for subnational regions of India and see, other divergences within the country in terms of effective coverage. You can plot that for different quintiles, so you can see whether rich people have better coverage quality than poor people. You can compare across different indicators to see whether there's more effective coverage process for ANC than for celebrities, etc. So there are myriads of options to have information on effective coverage across different countries, etc. So that's it for me. Again, just a flavor. I hope that it was of interest, and please feel free to follow up at the email with any questions that you check over the session. Thank you so much.
Uh, Thank you, Dr. Sven. We have one question from the chat. Let me read out to you. What are the tools that make it easier to create visualization, and what does visualization research generally cover? You want me to repeat?
Yeah, I mean, fortunately, for the tools, with the internet, and with open source software like R, but also discussions forums, data, etc. More and more kind of canned code, ready-made code, which only need to make slight adjustments to generate like fancy visualizations becomes available. And I think this is picking up speed. So I'm given my age, and when I entered the work. The workplace and kind of stopped advancing my skills. Like I don't even say that was before R became a thing. So I was desperately waiting for static code to become available for the various that maps. And finally, somebody got around to do that. So I'm very happy about that. But if you're like more at the if you're younger on the edge of research and technology, like R is available to you. There's a lot of stuff implemented.
I can add to what Dr. Nelson has said, with your permission, Prashant.
Yes, please.
Yeah, so basically, the question which was raised, actually, I think in the first slides, I remember Sven was showing that he is using the three platforms: Strata, R, and Tableau. So when you are doing the you can do a simulation and analytics and everything using your R and Strata. But when you are doing visualizations, I think the best platform which is available today, according to the Gartner report, also it is Tableau. And Tableau is available both in free version as well as in the paid version also, where you can bring out a large number of, you don't need to have a rocket science subject area on that, but you can certainly you can visualize your output. And also visualization is a very very important thing because it creates a lot of impact on that.
Yeah, fully agree. In fact, the work that for most of this online for visualization portals, that they use Tableau, we found it to be at some point limited in what you can do if you want to go for more advanced stuff and have give the user a bit more customization options. We found that R is a bit more powerful, but for the day-to-day use, Tableau is a great program.
Yep.
Thanks, Dr. Sven. I think we had only one question. So thank you, Dr. Sven. It was very insightful session and talk on research visualization. And I think technology is playing a big role in understanding the data much, much better than before. Thank you, Dr. Sven. So to move on, Dr. Shantanu Gongli, I would like to Dr. Shantanu Gongli for a session on knowledge management for healthcare. Let me introduce Dr. Shantanu briefly. Dr. Ganguli is a chief librarian in the B.B. Dikshit Library of All India Institute of Medical Sciences, New Delhi. He served in some of the leading organizations like University of Delhi, IIM Lucknow, National Productivity Council, Voluntary Health Association of India, IILM, and TERI. He is also editor of reputed journals and newsletters such as World Digital Library and electronic newsletters on renewable energy and environment. He is currently the advisor to Indian Council of Medical Research and Ministry of Environment, Forest and Climate Change. He did MSc, MLIS, and holds a PhD degree in marketing of special library services. So, without any delay, please welcome Dr. Shantanu to here on knowledge management for healthcare. Welcome, Dr. Gandhi.
Thanks, Prashant. Thanks for the beautiful introduction. And I just want to find out, can you see my slides?
Yes.
Okay, great. So first of all, at the outset, on the behalf of All India Institute of Medical Sciences, let me say I'll give big thanks to World Bank, the entire team of World Bank for coming together, and we had a lot of deliberations and discussions on that. Thanks to Professor Sharif, my professor in charge, Professor S.S. Chauhan, and my director, Professor Guleria, and others who have given me an opportunity to share some of the thoughts which I have, and also to organize this particular webinar along with the World Bank Group. And so basically what I would be discussing are slightly quite a different, because I was very much overwhelmed with the presentation of by Sven Nilsson, the Patrick, and my friend Peter and Ajay Tandon. Well, I would be taking you to some of the journeys from where actually lay the foundation by Professor Sharif, that democratization of knowledge, because that's become my tagline now. So data, information, knowledge, and wisdom I would be looking at, changing the landscape of the knowledge, and also the BB Dikshit Library. I'll give you a brief profile of that. The most important thing is that we all of us are aware of this DIKW Watt quadrant. And each step the pyramid answers the questions about how the adding the value to the initial data. So as we go up and we, the things from a bigger platform to getting more concise, more, more prolific, more, it is coming into more specific area, from a generic to specific, you can see the how the wisdom is coming at the end of it. Now, basic building block for any kind of a decision, as Ajay also mentioned, for policy making, for taking patient care decisions, and on one of the important thing is the data. So data is a very, very important. Already they have published a very interesting report on the World Development Report on this, and I find it is very interesting, and we have an enormous amount of data into that. Now, today in the healthcare sector, when I look at the big data in healthcare, we have the patient portals, we have the research studies, generic databases, electronic health records, public records, search engine data. You name things and which is generating. And this is a article which I came across from NEJM, and I find that there is a huge amount of data is getting generated day by day from the different data sources which are there. Now, when we are talking about an RDM today, or research data management, what does it mean? The types of data, the primary data, the secondary data. So we need to build a data culture actually. The scientific data which is available with us, the sociological data, the corporate data, the funders data. And there are the categorizations, and when we look at the proprietary data or global open data, and as a part of the knowledge management system, some of the things which we have seen in the previous presentation, like on data intelligence, data analytics, data visualizations, and in the current context, what Sven Nilsson was taking, he was showing a data visualization, but he was narrating an entire story of an antenatal care. These are the four major areas where the research data management is currently making a revolution, and we all of us need to understand that. So why healthcare data is very difficult? There are a couple of reasons behind it. Like, for example, the location, the data format, the data definition, the data structure, the data complexity, the regulations and requirement. It's quite different compared to others. So we need to understand this area. The next point, which is the second building block, is nothing but deriving the information. which is easy to measure, visualize and analyze the data for a specific purpose. Now, explicit information are published, which leads to the knowledge and wisdom today. Huge amount of research that is coming out today. And when I look at, there is a radical change has taken place, and I think they set the ball rolling by Industry 4.0 and Information 4.0. And there is a synergy exists between them. And this was, I came to know when Klaus Schwab was talking at, the World Economic Forum, and where he looked into that there was a time there was a information 1.0. But today what we are looking at, it is information 4.0. Why? Because there are multiple formats, there are multiple owners, there are multiple deliveries, and there are multiple publishers. So content which is there, 4.0, it is not one, but it has got a differentiation at every places. We need to understand, and it shows the relevance of the information changed over time with respect to the industrial revolutions. Am I correct, Professor Sharif? I think that's what you were trying to look at from index medicas of the hard copies to the current scenario of the changing paradigm shift which was taking place. So there was, a couple of journals when I was going through on the research journals, I find there is some unanswered clinical questions are there which impact on the patient management decisions. Approximately 2 out of 3 clinical encounters generate a question. And a physician have approximately 11 clinical questions a day. And 60% of them questions go unanswered. And what I'm saying that it is the data based on the data which was collected and it was published in these papers. So there are certain things people are looking for, and what is that? The trusted resource, the comprehensiveness of the content and the impacts outcome which is coming up in a big way. The next most important, the third building block is the relevant knowledge. How the pieces of the information, you have the small pieces of information, how they are going to be knitted together, they are going to be connected together to other pieces to understand how to apply the information to achieve that goal, what we are looking at. So some of the platforms which we use today, which has got a huge connectivity, your clinical key by Elsevier, the Dynamite Plus, the UpToDate, they are provided, it's a house of knowledge. They have huge amount of information, and where the doctors like Professor Sharif and all, they are constantly using it for the patient care management system. So there is a trusted resource at the back, and we need to understand that. And then comes talked about the open knowledge, which Peter has talked about. But today when we look at the open knowledge, it is nothing but the open science, the open data, and the open access. So this is an integration. We need to look at it. Now, there is a tremendous, when we talked about this particular area, that is SDG 3.0. So if you look at all the 17 sustainable development goals, each one of them are interconnected with each other as far as the data, information, knowledge is concerned. And which, if you touch one of them, the other relevant one of them get affected on that. And it addresses a lot of issues on those areas. So there was a book I came across, I was going through it by Henry Chesbrough. And Henry Chesbrough says that open innovation is moving beyond a single collaboration between individual organizations to networks and ecosystems of organizations, often collaborating through platforms. And if you go through this book, you will find that how open innovation is current context in bringing in a huge revolutions on that area. What is open? We are talking so much about open. Open innovation, as Henry Chesbrough mentioned, he talked about a very interesting concept called innovation funnel. Where open data, the enormous amount of data which is open domain, the data intelligence and the visualization, the open process, like for example, book prints. Today, publishing a book is not a very big deal. Open access to the research and the resources, and the open tools, and the techniques available, and the open code, and the open platforms, that is the open content on the MOOCs. So these are the 6 verticals where we are talking about addressing to the word called open. Open for whom? Either farmers, the knowledge workers, the health workers, the academicians, the policymakers, the researchers, the consultant, the organization, civil society, where there is a continuous knowledge exchange is taking place. So it is the research of the people, research by the people, and research for the people. So this is going to is the mantra, is the universal mantra today. I'll take an example of Project Digital Green, where a best practices of how to grow best quality of rice cultivation can easily be captured today with the help of a digital cam, a digicam, and the same best practices can be used by some other people. And there was a huge success. If I go through each and every case study, there is a huge case, and it is providing a huge amount of support for these best practices. A very interesting study, in fact, I have taken it from the World Bank report only. In Tanzania, the child mortality rate has been falling in recent decades. It remains 77% above the world average and 108 deaths per 1,000 children in order to address this problem. Tanzanian government sought to improve this nutrition and incomes in rural areas, restructuring its agriculture sector, particularly the dairy industry. So what they did, the Tanzania dairy sector, they approached the National Dairy Development Board, the Korean's model, and the Ministry of Agriculture. And the outcomes was there was an enhanced knowledge and skills, the improved consensus on the teamwork, and the new implementation of know-how. This is the beauty of the open access. A model, a policy which is efficient in one country is getting replicated on the next another country. This is what is most important in today's, and it is a very interesting case study of a Tanzanians learned from India's white revolution. So when we talk about the open, it is the knowledge divide, it is the skills divide, it is the digital divide, it is the experience divide, and the best practices divide. And the end of it, it is the impact. With the funding organization like World Bank, in fact, I was involved in many of the projects, I remember, and the stakeholders, we need to bridge the gap, and where they look into what is the research we are doing and how it is creating the impact on it. We need to bridge that gap. So where it is open access platforms and open content and accessible to anyone at any time. The top of the DI capable hierarchy is the guiding thing, which is the wisdom, which is at the pristine state. Wisdom is the knowledge applied for an action. Let me take an example of say for example, a doctor. A doctor, he gets all his knowledge, but some of the doctors, they use these 4 types of model, and I came across this research paper. They call it as a paternalistic model, where I decides for you, so he decides a kind of a medicine for him. Whereas an informative model, when they are going through, I give you the facts that what has happened to you. In addition, in the deliberative model, he talks about, in addition, I tell you my preferences. And an interpretive model, I give you the facts and help you to find out your preferences. So it completely depends that which particular model a doctor is basically trying to look at it. So most important thing is, when you look at a complete paradigm, in fact, some of the reports when I am referring to, there is a consultation experience and there is a longitudinal care. So a depth of relationship between a doctor and a patient care is knowledge, the trust, the loyalty, and the regards. And the entire evidence-based practices is based on best scientific evidence, the clinical experience, and the patient values. And this is the universal model which is currently is looked into in a very deep way. So what we have started talking about, from data to an information to a knowledge to an insight to a wisdom, and the end of it, it is an impact. Healthcare is a knowledge industry. It's not enough to have the right teams in the right place, collaborating to deliver the high quality, efficient patient care. What we need is today is the right knowledge and evidence at the right time. and this was given by the Chief Executive of Health Education England for Dr. Navina Evans. I was going through a report on this. So in the ambition, I would say the AIIMS has also embodies the same thing. So we provide the right knowledge and evidence at the right time in the right place, enabling high quality decision making, learning, research, and innovation. And that is where me and my team of Bibi Dikshit Library come into existence and come into play major players. So, building on the achievements, investing in a high quality digital knowledge infrastructure to meet the requirements of the staff and learners. In fact, Professor Sharif himself could speak for hour and hour on the digital transformation which is heading to. Empowering the knowledge and library services workforce with skills and confidence to deliver the vision. Shaping forward looking and innovative health knowledge and information service. So we need to look at some of the strategic framework, getting the right team, resources, and services in place, mobilizing the evidence and knowledge, enabling resource discovery, assuring the quality of knowledge and services, improving health literacy, and developing the knowledge and library services workforce. So, what is most important for me, and it is a challenge also, that I have to prepare my healthcare workforce for the new avenues, for the new opportunities, because it calls for knowledge based services, it calls for knowledge products and tools and the techniques, and it is not only just in time, but it is also addresses to just for me a customized solutions. Some of the vital role even in today's context, the knowledge specialist, in fact I am experiencing almost every day basis, me and my team, that is the know that's improving the patient outcomes and safety, informing the treatment options, reducing unnecessary interventions, shaping the policy. There's so much of changes are taking place, underpinning the education and lifelong learning, enabling the shared decision making, and facilitating the research and the spread of innovation. To equip the healthcare workforce, we search for evidence and good practices. That's what the platforms I've shown you, like up to date and all. Prepare the evidence reviews, response to queries, manage print collections, provide knowledge management functions, advise, training, knowledge assets based on the lessons learned, training in information skills, and enable the staff to access the e-learning. And in all these areas, in coming years, we would be coming up in a very big way on these areas, and some of the stuff we have already started working on it. So one of the important area where we are looking at today is healthcare information for all. Is a global social movement to improve the availability of use of reliable healthcare information and reduce the harms of misinformation. So libraries and information service have to play an increasing availability and the use of healthcare information. The researchers, the policymakers, the health professionals, the citizens all need to have an actionable information and relevant to their content in a language they can understand to protect their own health and the health of others. When I was going through the report of Medical Library Association of US, I found that there are some competency models. The first competency was the information service. A health information professional locates, evaluates, synthesizes, and delivers the authoritative information response to the biomedical and health inquiries. And there are certain performance indicators were already been derived. And if I start putting my people or myself into that, I find there are a lot of gaps. We need to fill it up. It's not a very easy to fill up this gap of performance indicators. Well, we need to have a lot of customization also is required for that purpose. Competency 2 is on information management. A health information professional curates and makes accessible bioscience clinical information. The competency 3 would be instruction and instructional design. A health information professionals educates others in the key skills of bioscience, clinical, and health information literacy. And the fourth point is leadership and management. A health information professionals manages personnel, time, budget, facilities, and technology and leads to others to define and meet the institutional goals. Competency 5 is evidence-based practice and research. So a clinical information professionals or a health information professionals evaluates the research studies, uses the research to improve the practice, conducts research, and communicates the research. And the sixth one is health information professionalism, which promotes the development of the health information professionals and collaborates with other professionals to improve the healthcare and access to healthcare information. So, knowledge for healthcare, what is there are three dimensions into that: the right resources, the right team with the right roles, and the right services which are provided. So, a new definition of research visibility is coming up into the picture. In fact, in one of the meetings, I was delivering a talk on this particular area where you need these three verticals. You need to discover, you have to engage, and you have to create an impact. Because research visibility is the coin today. So much amount of research visualization is taking place. I mean, research is taking place, but are we creating an enough platform for the visualization and the visibility? That's a most important thing today. So one of the important is research mobilization. So from access to impact, we need to go through each and every component of this journey. Access, connect, understand, apply, advocate. So we need to understand, and where is it? It is not only creating an impact in the social, economic, and academic, but as a whole, it is creating that. So research mobilization and open access is creating a big thing, and the mobilization. So there is an academic impact and there is a broader impacts into that. And that's related to data relating to the reach where you can create an influence. Resonance, which is important, and the results which can create the impact supports more nuances approach to evaluation and therefore unlocks the accelerated update of open access today. So if I look at the completeness, why don't researchers communicate work that is still in progress? So I could find in one of the report is that there is a n number of reasons that the research visibility is missing. So probably the knowledge is not getting transmitted the way it should be. I'll give you a very snapshot of BB Dikshit Library, which is not taking much time. A library with a healthcare service. So we have a library strategy. It's an integral medical university supporting the academic innovation, enriching the students' experience. We are equipping students for academic success, and my whole team is sitting here, and we provide service to more than 3,000 entire doctors fraternity, the clinical fraternity. We are providing the service. And all these dimensions which you see, all the 8 dimensions which come into the picture into it. So one of the important thing is providing the right guidance, the right decisions, at the right time, in the right context, in the right format. So we have a categorization of various kinds of web services, information service categorization, like basic library services, web-based research support and all. But all the research services which are provided, it's anytime, anywhere, inside the campus or we are outside the campus. Even during the COVID period, our all services were open, not only in the institute but outside. Everybody would be able to access the resources. We were never closed. That's I want to mean to say. So our services, value-added services, access to online resources, research support service, academic integrity service, reference management, and research to publication service. And access to online resources, like we have a huge collections of electronic databases measuring the research output, multimedia databases, and electronic theses and dissertations. Whereas major databases of clinical decision support system, what I mentioned in some of them, we have all like BMJ best practices, BMJ case report, the Web of Science Clarivate Analytics, the Scopus, the up-to-date. These are some of the CDSs we are already having. And we have almost 1,400 subscribing to 1,400 top-level international journals. We are subscribing. So there is a no dearth of knowledge. We have everything with us. So access to ebooks, Access Medicine, Oxford Medicine Online, OVD books collections and all, they are there. Even we are subscribing to the multimedia databases like Eckland's Anatomy and all. So we have a research support service. So constantly we have to provide a lot of service for our research purpose. So we have a research desk service, like my colleague Mr. Deepak is here, and other members are also there. So we provide a lot of remote access rights, assistance in academic integrity, document delivery, interlibrary loan, and all of them are there. So research support service is not only, in fact, many of them are coming to us when they are writing a project. We are providing them all kind of support. What are the best areas of writing a project? Like for example, writing a systematic review. So what are the various mechanisms of the writing a systematic review on that? So all these supports are provided to all my doctors. So research mapping is one of the major area where we're working towards it. So we have a research vision now, and we have created certain tools for the research canvas. And these are basically are the core value of strengthening the research base of AIIMS. We are constantly working with the research divisions to, and our mission is to knowledge mapping of the AIIMS research output, to map the research publication of AIIMS, to create an institutional repository of AIIMS publication, and to create a provision to intranet to visualize the research output, and we are heading towards it now. So there are three areas: capturing the AIIMS research base, visualizing the AIIMS research base, and strengthening the research base. So academic integrity is another area. So we provide a lot of academic integrity services like similarity index and all, paraphrasing and all, and academic integrity policy also. A diverse range of research articles are published. It's not a one type of article. It's because see, the biomedical sciences or the clinical sciences is completely different to other subject areas. I have been to engineering institutions or or management institutions and all. I have seen them, but the kind of articles which are published in a medical setup is completely different. The method article, the study protocol, the software tool, the systematic reviews, the data notes, the research notes, the antibody validation articles, the opinion article, the case reports, the registered report. So there are, I mean, you can imagine there are 10 verticals of based on which the research articles are published. Probably we are not aware. I was not aware of it up till now. But now I have come to know that these are the categories. And if you don't select your right resources, then it is very difficult for you to do that. Access rights using a remote access platform. So we provide a research access. Research to publication, we are doing a lot of hand holding with the people also. Like we, help them to write different kinds of, articles and all. We provide them a lot of support on these areas. We have an entire collections of, research publication where self-learning tools have been provided for learning on these areas. And these are some of the major areas where we work. So we also created a knowledge development program. In fact, myself and my colleague, Dr. Prashant and others, they were together, and we have been organizing such kind of an orientation programs. Like we will be coming up with book talk series or author workshop or tailor made for the nursing people. We have done, not only the clinicians, even the doctors, but the nursing people. We have done a lot of programs for them too, and using an appropriate tools for the research output also. So one of the strengthening of the research of AIIMS is accessibility, usability, and discoverability. So clinicians have questions every day in the course of routine patient care, but changing the decisions improves the patient outcomes. So access resource, and the best thing is that if you don't get an access to resource, or if you don't have a solution, so we are the solution providers. So please come and join us. And I will end this particular session by saying, Thomas Friedman, in one World is Flat, in one of his talk, he was saying, never before in the history of the planet have so many people on their own had the ability to find so much information about so many things and about so many other people. So with that, thank you very much. Thanks once again, World Bank, for having this webinar, joint webinar with All Institute of Medical Sciences. Thank you very much.
Thank you, Dr. Gangli. It was very, very insightful. Do we have questions, Dr. Gangli?
Yes, sure.
Yeah. So it was very insightful session. So to start with, we have question from our World Bank Chief Librarian, Eliza McLeod. There's a comment. This is a really key point on open for whom. There is often an assumption that by making research publication open on the internet, that this is enough. So that's a comment. Maybe you can highlight. And we have other follow-up question on other aspect. So could you please comment on this question? Maybe I can ask later.
Yeah, Prashant,
Yeah.
Prashant, can you hear me?
Yes.
Okay, so actually, can you just repeat the question once more? See, I think he's talking. I think your chief librarian is asked talking about your open access platform.
So I'll read out once
Can
more.
you repeat the question once more?
Yeah. This is really key point on open for whom. There is often an assumption that by making research publication open on the internet,
Yes.
so
Okay, I got it. So yeah, so it's a basically that's a very fundamental questions when I look at. See, even in the open access platform, you will find a n number of resources are available. But if you don't, uh, customize it in a such a way, or if you don't pinpoint that for the particular X content is meant for a person who is looking for such kind of an information, otherwise I mean, he's going to just what Peter mentioned, that he's going to float in the information overload or a knowledge overload, and he won't be able to find out. So it is better to churn those information, knowledge and all, and pick up the best ones. So it is always have to have a very focused who are our stakeholders and for whom we are creating, and we are, and that needs to be, and that is where your visualization makes, I mean, sorry, visibility, the research visibility. When I teach research visibility, it plays a very integral role. Whatever content you are preparing, you have a right stakeholder for that. And
yes, perfect. We have a follow-up question on that. Do you run into what I call the overwhelming faith in Google for all your answers? So, what is the behavior of your library patrons, their research process? Do you face issues on keeping up with cost for scientific information?
well, first of all, I know I'm going to get a question like this, but let me tell you, Google is not an answer for my doctor's fraternity. It is not that, because in the Google you get a lot of informations, but many of the informations are, as far as the clinical or biomedical information are concerned, they are not available so free, and there are a lot of information overload takes place in the Google itself when you do a particular search. So in today's context, when I interact with all my users fraternity and all, I generally interact with them, and I take them to the right platform also. In fact, we also subscribe to quite a good number of databases, resources and all available in open online. But it is always better to take the right person for the right resource at the right platform. It is always important, and that is where I play a very important role into it. Not only me, in fact my team also. They always educate them on that which particular platform they should look for, what kind of information and all. But there is a, yes, there is a lot of challenge. Many people, they always make a basic search before coming to us, and they say that we have come across this information, so can you get us? Well, under the sky we cannot have everything. So probably you can look into some of the things in the Google Scholars, or we generally get it purchased or maybe subscribed, or maybe on an interlibrary loan from some other institutions also. That's how we play our role.
Thanks, Dr. Gamlu. Hope it answers Eliza. So, yeah, it's like right guidance with right resource at right time to take the right decision. Thank you, Dr. Gamli, for the insightful session. So our last, yeah, thank you, Dr. Gamli. So our last presentation for this event is from Sheena Chabra. So, hi, Sheena. Can you hear us? Just checking.
Sheena just texted, there was some glitch. She's trying to join back.
Yeah.
Okay.
I'm sorry. I don't know why in the middle I was just, it just seemed like I was thrown off the webinar. So I'm glad that I could join back.
Yeah, thanks, Sheena. So let me introduce briefly. Sheena Chhabra is a senior health specialist with the World Bank Health, Nutrition and Population Global Practice based in New Delhi, India. In her career spanning over 3 decades, Sheena has a strong track record of impacting national and state health programs related to universal health coverage, maternal and child health, infectious diseases, and water and sanitation, covering areas such as health policy and strategy, health financing, health system strengthening, etc. Prior to joining World Bank in 2016, Sheena headed the Health Systems Development Division of USAID, India. Prior to that, she was a senior project director at the Social and Rural Research Institute and a lecturer at a Lady Irwin College, Delhi University. So without any further ado, please welcome Sheena, who will speak about knowledge translation.
Thank you very much for the invitation, and good morning, good afternoon, good evening, wherever you are. It's always hard to be the last speaker. I will try and continue to retain your interest as I share the work that we have done on the Annual State Health Index, which is really a very good barometer for tracking performance of the states on an annual basis. Though my focus is on the last round that was done, but we will see how this has become a very important benchmarking tool in India. Okay. In terms of the State Health Index, this is an exercise which has been spearheaded by NITI Aayog, which is the Government of India's premier think tank, along with in very strong collaboration with the Ministry of Health and Family Welfare. World Bank has been providing technical support in terms of the development as well as the implementation of this annual State Health Index. This really emanated from the National Development Agenda, which was chaired by the Prime Minister. And all the chief ministers and the governors of the states and union territories are part of that National Development Agenda, where they prioritized three things. One was health, the other was education, and the third was water. And said, how do we track performance of states and union territories on all of these three agendas? And with that, the whole idea was that there would be a health index which would actually look at not only in terms of at its particular point in time where the states and union territories were in terms of their health aspects and how they were managing them and what were the outcomes. But will also be an instrument which can look at tracking year-on-year progress. So with this, in terms of the health index, it's really a weighted composite index based on 24 indicators. And there are three domains that are looked at: health outcomes, which looks at both the intermediate, the key outcomes as well as the intermediate outcomes. There are governance and information indicators, as well as key input and processes indicators. So when I talk about key outcomes, at the highest level ones, we'll be looking at indicators like neonatal mortality rate, urban, the under 5 mortality rate, the sex ratio at birth. So these are some of the key outcome level indicators. In terms of intermediate outcome indicators, I think we have really indicators which are, around what's included are things like the contraceptive prevalence rate of what contraceptives, full immunization rate, looking at different programs, people with HIV or treatment of with the ARTs, CV success rate, etc. Those are the kinds of indicators which we are looking at the intermediate level. Then there are also a host of governance indicators which actually look at both the stability of tenure of the leadership positions at the state level in terms of for program implementation and program progress, as well as it has indicators to look at the flow of funds. Once like for federal schemes, when do funds when they get transmitted, at what point do they really become available at the level of the implementation agency? So those are the kinds of indicators that's looked at. Also in terms of data integrity indicators, because when we look at health management information systems, very often we say the quality of those data are not very that good. So how do you really look at systems and incentivize systems and see what's the kind of quality and data integrity of what's coming out of those? So that is part of the governance indicators that are also looked at. Then there are a whole range of inputs and processes indicators, which are really looking at various aspects of, in terms of these range from availability, looking at the certification of quality of the different facilities in terms of whether they're accredited or not, availability of and access to first reference units, also looking at registration of births and deaths. And in this, a very important indicator is the HR indicator, which looks at in terms of the shortfall of healthcare providers at the different levels and their integration within the human resource management information systems are the kinds of indicators that are looked at. And I'll get into more details later, but just wanted to give you a flavor of the kinds of indicators that are included in across the three domains that we have. So with this, the entire exercise began in 2016, where the whole idea was to develop this index. And we started with over, nearly 300 odd indicators. And there were few parameters that we looked at in terms of the development of the index. One was that there would be no fresh primary data collection exercise that will happen. There are some data which stay through the administrative systems, also captured, and that's included in the index. But otherwise, largely it was looking at sample registration systems which are available, looking at the health management information systems that are available, and then also looking at some of the state reports, etc., that I have mentioned. So that was one criteria. The other was that recognizing that there may be data that are not really gold standard, but to the extent that the data are fairly good quality and something which is available every year so that you could be able to track year-on-year performance, because that was the other aspect which was really important in terms of what was included and what was not included. So we went through a range of 150, over 300 indicators, shortlisted about 150, then came down to about 57 indicators. Based on that, we started developing the index, did pre-tests to see the kind of quality of data that was available, looked at the trends in the available data, etc. And then that's where we sort of shortlisted 24 of these indicators. And in the last 4 years, every year there has been a release of the Health Index report. And as I had mentioned, this is something which is really in partnership with the AIO, Ministry of Health and Family Welfare, and the World Bank. And the last report was released actually in December of 2021. So basic objectives of the Health Index are really to look at this as an enabling tool for states and union territories, where the whole idea is how do you equip states and union territories to be able to track their performance. So this is something where they can track their performance at a composite level, at the overall level, in terms of year on year, whether they have improved or not across the various indicators that I mentioned. And what it also does is that at an indicator level, one is able to see what the delta of the change has been. And this is something which is really important because, historically, a lot of times when we talk about health systems, we know Kerala has the best health system in India. We also know states which are not so well performing, like Uttar Pradesh, etc., which don't have such strong health systems. But the whole idea of this index was to focus on the delta, to focus on the incremental change, so that even states that have historically lagged behind, they could see that how, what kinds of changes are they making now to be able to catch up. So in some ways, you're looking at the delta against your own performance, and you're also seeing how you compare across in terms of the peers. The other thing what has happened is very often in the health sector, we have focused on inputs and rather than outputs and budget spends. This is the first time the focus is actually shifting from inputs and budget spends to focusing on the performance and what has been achieved. And what's really very heartening to see, because we've seen the journey across the 4 years. What started off in the first year, when the report came out, I think what it did was earlier what started with something which was a health sector exercise actually caught the attention of the chief ministers of the states, where they started saying, okay, what has happened? Why hasn't the state performed? Why is it lagging behind? Why other states have done so? In a way, it spurred a lot of competition among states to do better and accelerate the pace of achievement of the health outcomes. What it also offered to do, because when you analyze the data and you look at some states have done better than others, some states have done better on certain indicators than the others. So what it has also done is provided an opportunity for cross learning among states in terms of how they have made the progress within similar kinds of socioeconomic conditions that exist in across the states. And amongst the peers, especially that is something which is really in terms of given a lot more thought and knowledge exchange that's happening around that. And so a lot of sharing of experiences have also happened. The other is that the administrators have found this tool to be very important, and they've seen what kind of, in terms of action that it has generated in the state. Some of the states have gone ahead and adapted this tool to monitor performance at the district level. So the way the whole index is constituted, I've already talked about the kinds of indicators that are there, so I won't delve into that again. But the focus here, as you can see, the weightage of the index is much more on the health outcomes, the key outcomes that I talked about, and the key intermediate outcomes, than the key inputs and processes. The other thing the index has done is really looked at categorization of the states into the larger states, smaller states, and union territories to be able to then have comparisons within similar entities. Also, we see that the availability of data for smaller states and union territories on some of the indicators is limited. And therefore, for instance, the key outcome indicators which come from the sample registration survey, none of those indicators are actually available for smaller states and union territories. Ensuring that the focus for the larger states, you do capture key outcomes. So based on all of this, this is how the index has been constituted. This is just to give an idea of, I've already spoken about this in terms of the kinds of indicators that are there. So this just provides you, at a glance that you can see in terms of how this is looked at in terms of, so it does cover various aspects of and across, programs. It tries and covers the various tracer indicators. In terms of SDGs, it does cover some of the SDG targets and tracer indicators related to the SDG goal 3, like the neonatal mortality rate, under 5 mortality rate, the maternal mortality rate. This one looks at institutional birth, whereas the SDG target is around skilled birth attendance, but it's a similar indicator, and also looking at the total case notification of TB. It also looks at tracer indicators that are covered in the index around what I had mentioned about TB cases that are detected and treated successfully, the HIV on ART treatment, and also some of the indicators related to child immunization, pregnancy delivery, and health workforce are also covered here within the index. And we're trying to cover as much in terms of looking at the availability and also looking at that you are able to represent a wide range indicators, and by keeping the overall number of indicators to less than 25. This I've already spoken about, the categorization, just to tell you how the states exist. So what it does is, at the extreme left, you can see the ranking of the states in terms of the overall performance. And what this does is in terms of, it tells you that in terms of the overall performance, how do different states compare. And as I was mentioning, no surprises, Kerala ranks on top. Uttar Pradesh is really at the bottom. However, what's really interesting is if you really look at the middle, the green and the red bars, even though, in terms of overall health systems, you find that that's how the performance is. But what one sees is in terms of the changes that states are trying to make, and actually Uttar Pradesh, Assam, and Telangana came out on top in terms of the year-on-year change or the incremental performance. And it also tells you how you compare overall in terms of ranking across the composite index and a year-on-year and incremental change. And this is the kind of thing that one can see year-on-year at the overall level. The other big message it tells is even states that have performed well, in terms of the distance from the frontier. So if you really look at Kerala with a 82.2, it's still, the frontier is at 100. So still it is quite a way off that, states like Telangana, which have made tremendous progress both in terms of overall, where their ranking is concerned, as well as in terms of incremental change. But it's really at a 69.96, which is quite a bit in terms of the distance on the frontier and the progress that can be made. So it's not only for states that are not performing overall, but for all states, I think that's the kind of message that goes. It tells you year on year whether your ranking has improved. The green lines are showing that your ranking has gone down or it's stagnated. It helps you also see at the level of the overall, the 24 index indicators, where there have been very good improvements to, what you see in greens, to where you may have stagnated and there has been no change in yellow, and then where you have deteriorated in red. So we've used the traffic lights and the different shades to sort of indicate some of that. And then, within that, then you can also see in terms of which are the indicators on which you see progress in vast majority of states, in which you are seeing that, the states are not really doing very well. And that kind of analysis actually also brought to fore that on quality parameters, irrespective of the states, we saw that most states did not really perform very well. So it's also those kinds of messages that get highlighted with this analysis. Similar analysis across smaller states and UTs. The other is the point that I was making in terms of overall performance and incremental performance. And what it tells you is, there are states like Rajasthan, Arunachal Pradesh, Manipur, which in terms of overall performance are not doing well. At the same time, at current times, you're not seeing that they're trying to really improve and make that change. Whereas you have front runners like Telangana and Mizoram at the bottom, where in terms of overall performance, they're doing very well, and they have also shown most improvement year on between the last phase year and the reference year this time around. Then you have states like Assam, Uttar Pradesh, Meghalaya, Delhi, Jammu and Kashmir, and Ashwadi, which are at the bottom, which in terms of overall performance have not really done well, but they are really making efforts to make that improvement, and they are amongst the most improved states year on year. So this kind of thing also tells you what are the kinds of patterns based on historic performance and what you are seeing in terms of current trends, and it's able to highlight some of that. And what we have done is there are in the report there are various tools. Very often what we found that administrators want a cheat sheet where they can see how do I compare. What is my overall indicator performance, and also what has been the year-on-year performance of each of these indicators. It gives you the value, and it also gives you whether you've improved, not improved, or stagnated. And that's the kind of cheat sheet that's available for each of the states and duties in terms of the analysis that is present. What it also does is, as I said, this has really helped to generate competition among states. And what it also does is, it has heat maps where you can actually also compare various states and see how is my performance compared to some the other states within my own category of larger states or smaller states or UT, where have you been, in whichever category you belong, and then also sees what that magnitude of that changes. So it captures both overall and indicator, incremental performance, and provides you a snapshot of that and the comparison across states. What it also does is for each of these indicators, it also provides trends across the years and looks at the kind of change that's there. So, like this is an example where in terms of full immunization, one sees, between 14, 15 and now, Uttar Pradesh has made progress, and, Uttar Pradesh, Madhya Pradesh, and Jharkhand, which are not so well performing otherwise, but they have made a change and they have made positive gains in terms of immunization amongst the highest across the different states. There are states, where, like, if you look at Kerala, which overall does so well, but actually on the indicator in terms of trends, it's going down over the years. So it also shakes off some of the complacency that the states may have, which are better performing states. So, in the end, what I would like to share are some reflections, because the way the health index has been developed has evolved over time. It's always recognized that this is work in progress. There are continuous refinements which are made as new data becomes available, data systems improve, and there are so many indicators. I'll give you an example, like maternal mortality rate. When we began the index, we could not include that in the first round because SRS would not generate the data for all the large states. The data were not available. But over years, with advocacy of both NITI Aayog making, as well as the Ministry of Health and Family Welfare, on what are the indicators on which you do want the data to be available. Also, what it has done is, because the whole, in terms of, there is an independent validation agency that is also hired by NITI Aayog to look at the data that is generated. So it's not like any data gets accepted. So there are a lot of discussions around the quality of data, especially the HMIS data, where some of the data sources are based on HMIS data. And looking at that, what it's also doing is refining and helping improve the data systems, the quality of data for those indicators. The other thing, what it's also doing is currently, there are several indicators, like whether we look at out-of-pocket expenditures or how one is looking at financial risk protection. Currently, we don't have an annual data source which is available that can be used really. And it's an important gap in the current index. So there are discussions on what can be done to include some of those indicators relating to NCDs, coverage, indicators relating to mental health, etc. So those are also things where there is constant discussion and dialogue in terms of improvement. So it's not only what it does to measure the performance, but also the continuous dialogue to improve data systems, improve availability, and improve the timeliness of reporting, which is happening with this. And as I had mentioned, some of the indicators are not available for smaller states and UTs. So there's also that ongoing dialogue that's there in terms of how you look at that. But one important thing which we have considered and have sort of looking at the practicality of this, this is something for intermediate and service delivery indicators. Not really being able to do that field level audit in terms of the data quality, because that becomes like doing the large scale survey every year. So that's the reason why the data integrity indicator was used, which actually looks at the NFHS data and looks at what is the kind of deviation between, say, full immunization and antenatal care when you have large scale population surveys, which are quality surveys vis-a-vis HMIS period of data of the same period. So those are in fact looked at instead. And so those are some of the things in terms of the index. But as I had mentioned earlier, what we have seen that this index has really become a potential game changer and has helped in terms of shifting the focus from the budget spend to inputs and outputs. There are questions that are asked based on the performance of the data. The additional chief secretaries and the chief secretaries are using this to monitor the performance of their states and really shaping the complacency of states, as I mentioned, which have historically done well, but if we look at it in recent years, they're not making as much progress in helping, also improve the whole culture of the use of data to monitor performance. And that's something which has been the most heartening process, because we say, what's the data and how it's being used for decision making. And then that's something which we have seen 4 years. There's still miles to go, but in terms of really seeing the change that is happening, and which has also generated the commitment at the highest level to improve the availability of data, the quality and the timeliness of the data, and looking at ways in which the states themselves started looking at how do I verify the data that's coming from the programs and how you spend that. It has helped to standardize some of the definitions, improve the, make them much more specific in terms of what one is really looking at, and also expanding the range of HMIS indicators that I had indicated. So that's broadly in terms of what I would like to share today in terms of how the health index is really looked at feeding the pulse of in terms of the states, in terms of the progress that has been made and how it's being used. If you're interested in the report, it's available at the EPIO website or in the public domain. There's also a portal in which actually the data are available, and this is something which actually the researchers can also download and look at trends and do further analysis. So that's what I would like to share. Thank you very much.
Thank you, Sheena, for the insightful session. It was very, very informative. And yes, the application, dissemination, and exchange of knowledge is important to improve the healthcare system. Yes. Thank you. We do not have any questions at the moment. So if we have any questions, we'll forward to you. So thank you, Sheena. We have now completed a series of keynotes presentations and their thoughtful contribution in their respective fields. So we apologize, we are slightly over time. So we are concluding this event. So over to you, Deepak, for the conclusion.
Thank you, Mr. Prashant. Now I would like to invite Duncan Omle, Head of Research, WBG Library, for vote of thanks. Mr. Duncan Omle is the Head of Research at World Bank Group Library with many years of experience in information management. He is also the ITS Knowledge and Information World Bank Data Lab lead. Duncan experience at the bank also span many years. Over to Mr. Duncan Omle.
Thank you. Good morning, good evening, depending on where you are. Thank you everyone for attending the Digital Health Knowledge Connect 2022 Paradigm Shift in Research Information Management System. It is a true honor for the All India Institutes of Medical Sciences to partner with the World Bank to deliver this joint webinar. And to our AIIMS partners, what a pleasure it is in getting to know and learn about you and some of the services and products that you offer. For instance, some of those programs that I learned, I think Dr. Ganguly, I believe that's the name.
Yes.
Made a
You were right,
presentation
Ganguly.
on the focus on discoverability and usability and accessibility in terms of the research programs. And I know there's also something that is going on right now about just reproducibility of research itself. And those are areas that are very important for any research work. I wanted to specifically thank Dr. Shantanu Gambuli, the Chief Librarian for AIIMS, and also our own Chief Librarian, Eliza McLeod, for allowing our teams, our respective teams, to participate in this and also facilitate it to be very successful. And also, obviously, our health practice well-management team. As you know, health is an important development agenda. There is not much you can do if you are not healthy. And health impacts every facet of our lives. And if you're in doubt, you just need to look at kind of what's happening right now, what we just gone through in our lives. We had this coronavirus, corona pandemic, and you can just see the impact that it's having every facet, including the economy, transport, supply chain system, education. So it kind of affects everything, and it's important to be able to talk about all this. I wanted to thank our World Bank Group Health practice partners, and especially for the presentations you made on the World Bank perspective. And we welcome you to continue to partner with us. As you know, the library has a lot of premium resources that you can use, including PubMed, Science Direct. We have the Cochrane Library, for instance. It's the only one that I know that has systematic reviews of the effects of healthcare interventions. And we all have that on the desktop for you. We have AIIMS, we have Fitch, we have Activa even for news, and we can always set up alerts for you. To our AIIMS partners, while you can access some of these about premium resources unless you subscribe to them, we are always working with our health TTLs in making sure that the health delivery programs have the information they need to work on the projects, and we are glad to continue enabling this work that they do. In fact, I'm pretty sure that Dr. Sheena Shabra, that the health index, state health index that you were making a presentation about, I'm pretty sure that the library was, in some ways, helpful in providing the background information and even sharing some of the best practices. And they're always ready to continue to do this. But I also wanted to mention that the library has these free online resources that you can use even if you are not a staff member or if you are not subscribed to some of the other resources. It's very extensive. I'm pretty sure the organizers can share this with you after the presentation. It includes things that are published by, for instance, INARI, which is the health information system produced by the WHO, and it is freely available from all these journals that are peer-reviewed and very high quality. So in conclusion, I wanted to thank our organizers, the leads for this, Amita and Prashant, did a wonderful job. I want to thank all our presenters for attending this session and also for making the presentation that have been very, very insightful. Thank you for sharing your precious time with us. And I just want to say that may everyone in India have a wonderful evening, and for the rest of us in the Western Hemisphere, a wonderful morning. Thank you.
Thank you, Duncan. That was very interesting. Thank you, Duncan.
Thank you, Mr. Omle. Now I would like to invite Dr. Prashant Srivastav for closing remarks. Dr. Prashant Srivastav is serving as Health Science Librarian in B. Dikshit Library, AIIMS, New Delhi since last 18 years with various important responsibilities. His area of proficiencies are e-resource subscriptions, access and management, health knowledge, resource development, digital libraries, research data management, research data literacy, research data repositories. He has published various research articles in leading AIIMS publications and also reviewer in AIIMS journals. Over to Dr. Prashant.
Hello everyone. Myself Dr. Prashant Shrivastava from BB Dikshit Library, AIIMS New Delhi, presenting closing remarks of today's webinar. Respected dignitaries, ladies and gentlemen, and dear professional colleagues, thank you very much for your cooperation. I appreciate this opportunity to deliver a few concluding words with a little bit more of your patience. First and foremost, I would like to express my appreciation to the speakers for their valuable contribution to this webinar under webinar series of Health Knowledge Discovery and Learning Development HKDLD program, AIIMS New Delhi. BB Dikshit Library, AIIMS New Delhi, is organizing webinar series in the field of healthcare knowledge services. BB Dikshit Library wish to conduct these webinar series to encourage and engage not only AIIMS New Delhi faculties and doctors, fraternity, research scholars and students, but also to sensitize the digital health across the globe. In this webinar series, we have invited leading national and international speakers in the field of digital health knowledge sectors to discuss and deliberate on how hybrid learning environment addressing the requirements of the doctors for the clinical decision support systems to create a network of medical knowledge professionals across the globe working in different areas of healthcare support and services to understand and providing relevant knowledge services to clinicians how the core competence of the medical library professionals are changing or going to upgrade in latest environment to bridge the digital gap between have and have nots to exchange and learn from each other's best practices, skills, and expertise to bring to innovation in medical information and knowledge services to understand new areas of research-based knowledge and data services. This webinar discussed very prominent topics of open knowledge maps, research visualization, research management for healthcare, and knowledge translation. Today's speakers discussed very relevant topics. Professor Sharif discussed paradigm shift in information technology and digital transformation era in all areas with healthcare. Further, Dr. Ajay discussed data for better life and data application in recent advancement. Further, Speaker Peter discussed the SDG 3.0 and open knowledge financial protection in healthcare. Peter Cracker discussed the open knowledge map tools for scientific knowledge and how to map a research topic. It's very relevant in this age of information overload. Further, Swain Nielsen discussed the research visualization on universal health coverage concept that everyone receives the health services they need without suffering any financial hardship, financial protection, and effective coverage. Further, Dr. Ganguly discussed in large knowledge management for healthcare, discussed open knowledge and its applications, discussed competencies and performance indicators for health information professionals. Sheena Chabra discussed the state health index for India and detailed discussion on indicators related to healthcare progress. Now, I would like to thank competent authorities of All India Institute of Medical Sciences, New Delhi, to allow us to host such a fruitful webinar with the World Bank. I want to thank enthusiastic and dedicated teams of BB Dikshit Library, AIIMS New Delhi, and the World Bank to put their heart and soul to make this event happen. We are also thankful to AIIMS New Delhi, CMAT, and SET facility to provide great support for this successful event. My greatest gratitude goes to all participants who attended this event. I am very pleased to inform you that around 700 participants, more than 700 participants, belong to more than 26 countries from different parts of the globe, helped us to make it such a successful webinar. Soon we will try to connect you again with new knowledge and vibrant topics. Till then, stay safe, stay healthy. Have a nice evening. Thank you.
Thank you very much, Amita. Thank you. Thanks, Prashant. Thanks, the entire team. Duncan, Devendra, Tandon, Mr. Tandon, Ajay, and others. Mia, Tibu, Raphael, everybody, thank you very much. It was wonderful. It was, thank you very much. Thank you. Thanks, Akam. Thanks, everyone.
बताइए